My name is Parisa Mansouri. I'm research lead at MQ. And before I forget, I should thank great efforts of my MQ colleagues for organizing today's event. Hala and Tilda, who are there. I'm sure many of you have heard from them so far. Also, we appreciate Deutsche Bank, who have provided us this beautiful venue for free. We are not super rich as a charity, but we have this corporate partnership with Deutsche Bank, and one of the perks of this partnership is getting this venue for you. In terms of housekeeping, I hope you all know where the toilets are by now. So the nearest one is that way. You just need to go straight. And there is no fire alarm planned for today. So if the alarm goes off, we're in trouble. You will need to follow people with a yellow vest. And there's just one fire exit down the reception. Just follow the people in the yellow vest and they will rescue us, hopefully. And now to the workshop. So today's workshop is, because as you might know, we, as part of our work with DataMind, we have a series of training activities for early career researchers in DataMind and mental health research. And this is one of the workshops as part of that series. And this one is going to focus on use of clinical data for research. And we will start with Matthew and Amelia today. Matthew Broadbent, he started his work at the NIHR, National Institute for Health and Care Research, Maudsley Research Center, Biomedical Research Center in 2007, where he managed the development and implementation of CRIS, and you will hear more about CRIS today. Matthew now manages the Biomedical Research Center's clinical informatics services, including services supporting the use of CRIS, natural language processing, and clinical data linkage service. So I guess all very relevant to today's workshop. And then we will hear from Amelia Jewell. Amelia joined the NIHR Maudsley Biomedical Research Center in 2015 as the clinical data linkage service lead. And her role involved managing the clinical data linkage service, including project managing CRIS data linkage, and in her current role as research informatics and governance lead, she's responsible for managing all aspects of the CRIS research informatics service and the clinical data linkage service. I tried to avoid acronyms, it was difficult. So over to you, Matthew, good luck.
Thanks, Parisa. Well, welcome everybody. What I'd really like to do is to ask you all to introduce yourselves, but I don't think we've got time for that, unfortunately. Do you all know each other, or are you all sort of new to each other? I'm guessing kind of a bit of both. I mean, maybe it'd be helpful, I mean, just in literally 2 or 3 minutes, if you just introduce yourselves to each other on your tables, perhaps. I think there will be some interaction today. If we just spend a couple of minutes, if you haven't already done that, just to introduce yourselves, would that be okay? That's great, thanks very much. Well, I will ask you though, because we're obviously talking about clinical data today, just as a show of hands, how many people in the room here are clinicians, doctors, nurses, psychologists? A smattering. Okay, that should help. Not necessarily, but it should help. We'll see, we'll see. So for the agenda for today, I'm not going to introduce Risha and Katrina, they'll be introduced later on. What I will say is that Risha and Katrina are both academics who've used CRIS, or used the services we've set up to access clinical data for research. Amelia and I are more from the service side, and we're going to be talking more generally about clinical data and the idiosyncrasies of that data, and from our experience, at least the options or perhaps the recommendations of how to deal with those idiosyncrasies. I should say most of what I'm going to be doing, and Amelia, is a bit of a slideshow. We will have, I think, have time at the end for questions, but by all means, just interrupt as we're going along if you feel that you've got anything that you particularly wanted to ask. I reserve the right to change my mind if we're sort of taking too long, but to start with, please do feel free to interrupt if you'd like to. I'd like to start where we started back in 2007. There are about sort of 4 or 5 of us sat in a room with a door shut, and we ask ourselves the question as to what might be the purposes and the benefits of accessing clinical data for research, which was a sort of novel idea at the time. The two purposes, sort of the headlines, if you like, that we came up with, well, the first was to identify potential recruits to trial. And the second was essentially for health service research, longitudinal, retrospective health service research. And the nature of the data and the benefits of the data, obviously we're talking about real world data. And the great benefit for us in terms of real world data at that point is it gives us a potential for real world impact. Now, we were funded by the NIHR for these things called biomedical research centers. And our raison d'etre was translational research, or research, I think the catchphrase they used was from bench to bedside, with the idea that you had a much more research that would have a direct impact on frontline clinical services. So to have this real world data with a real world impact was a very significant ambition. And there was a hope, as you might have guessed, that the data will give us significant power in terms of size, which we'll come on to look at. That's where we started. But, and it was a big but, and it was a big but in the room for us at the time. It was probably an even bigger but outside the room within the wider Institute of Psychiatry where we were based. And there were significant questions at the time about the data and whether clinical data would ever be good enough to use for these purposes. The kind of main thrust of the argument was that these are not obviously research data. They've not been meticulously collected by an RA who's sat down and carefully gone through a questionnaire, for example, with a patient. Rather, these are health data collected in chaotic, often very busy clinical settings where rigor is tricky, shall we say. The implication being obviously they're going to be data quality issues. And I think for most people who've accessed data for research, certainly, well, access data for reporting purposes, that's proven to be the case, both in terms of accuracy and completeness. And that is certainly true. And you don't have to actually to look very far to find these kind of issues. I'll give you some examples. So this is a question that somebody asked us not that long ago. How many days are there between a patient's last face-to-face contact and their date of death? This is for patients within our service at the Maudsley Hospital. So we pulled off a report in response to that question, looked like this. Here you can see a patient ID. That's the date of their last face-to-face contact at the Maudsley. You can see here this top one of 2018. That's their date of death, 1998. And that's the number of days between the two. But obviously the sharp-eyed of you will notice that in this case, somebody who's been seen about 20 years, so they've died, that's been seen about 20 years after they died. And in fact, this is a list of all the patients in order of the number of days after they died that they were seen. And in the Maudsley Hospital, there are actually about 1,200 patients who've been seen after they died. That's out of about 50 to 55,000 patients who have died. That's accuracy. If we look at completeness, this is another question that somebody asked a few years ago, this one. They wanted to do a study, and they're interested in the impact of housing and employment status on clinical outcome. And they asked if they could look at our data dictionary and see what was in the data set to see if they could pull out stuff on housing and employment. And they looked at our data dictionary. This is what they found, kind of front and center, the main patient demographics table. Here you see some fields relating to housing status. Here are some fields relating to employment. And they thought, hooray, job done, we'll use those. Until they saw the data. I pulled these out just a couple of weeks ago. This is out of 450,000 patient records. This is the information on who somebody lives with. So over 60% the answer is dunno. That's pretty good in comparison to housing status, where if you add up a null value, a not known, and frankly a rather questionable other field, it's over 90% incomplete. That's for the housing status lives with. So then their reliance on employment, we see something fairly similar. Occupation, 90%, over 90% not completed. Employment status, if anything, even worse. So after the brief flurry of excitement, how do housing employment status impact on clinical outcome? The answer was pretty hard to tell. The reasons for that, well, maybe the reasons are pretty obvious. Simple typos, other data entry errors, and certainly you can see that. Returning to our cases of those patients who were seen apparently after they died. This is from one patient's record. Here you see a date of death. Don't know if you can see that, but that's 18th of January 2015. And here you see their face-to-face contacts. Now, about a year later, 2016, another one here, also January 2016. And if you look at the text from that, the sort of the relevant bit here, patient died 5 o'clock on the 18th of January 2016, as opposed to 2015. Simple typo. But it's not always quite so straightforward. And if you dig a bit deeper, you sometimes find a rather different story. So here's another example of a patient who apparently was seen after they died. So we've got a date of death here, February 2010. And again, we've got 2 contacts afterwards. So one a few days later, we've got another one down here about 6 or 7 months later. And again, if you look at the text, you see a revealing picture. In this case, telephone call to son to say, thanks for letting me know about his mother and to express my condolences for his loss. So clearly the contact has happened. It's just happened with the son. And actually down here, so several months later, home visit to Mr., that's the surname, to feedback from investigation into circumstances surrounding his wife's accident. So there were face-to-face contacts, just not with the patient, with family members. And actually, if you look at those deaths, which apparently there were contacts afterwards, I haven't actually done the total count, but at least 50 to 60% of them were legitimate face-to-face contacts, just not with the patient themselves, they were with family members. And often there are quite consistent long-term bereavement counselling, for example, it may go on with patients' family members, recorded in the record of the patient, because that's the only way really to do it, unless you ask for the family members to be referred. Completeness, again, we also, if you start to look in detail, the picture is not quite as straightforward as it first appeared. Here are 3 records, just randomly in order, of patients for whom, again, we look at our employment status, not known, not known, not known. But I just did a simple text search in the records for those patients just on the word employment. That's just the word I chose. Patient number 1. She trained as a nurse and worked as a midwife before she had her children, since which time she's not worked in paid employment. Clearly, it is known. Same thing down here. This in turn has meant she's unable to work and unable to hold down full-time employment, etc., etc. And then there's a similar thing down there. Mrs. Ed has explained that she works as a tour operator. And that's not uncommon. In fact, employment status and occupation are things you would expect to be recorded routinely and investigated, but just be written down in case notes, not necessarily in this kind of a structured field. So to reiterate, we start with this question, are the data good enough? And we've got a skeptical group who are saying, well, we don't think they are, and they can't be because this is not research data, it's clinical data. But, and this is a slightly smaller but, just from those examples, if you dig a bit deeper into the data, whilst it's very true that clearly there are data quality issues, they're not always quite as straightforward as you may think they are. The picture is a little bit more complicated. And maybe the problem sometimes is us, not the data. Maybe we're looking for the wrong thing. Maybe we're looking in the wrong place. Maybe we're looking for the wrong patients. This is an argument that was put forward in counter to this skeptical argument about the data are never going to be good enough. And the argument at the time was made was this. It was saying, okay, sure enough, these are not research data, but that's okay. They are health data, they're clinical data, but you have to remember, rather than thinking that clinical data is inherently bad, look at it the other way. Clinical data actually are inherently good. We know that clinicians are required to record good quality data. It's a legal requirement as well as a professional requirement. So you should start with that perspective rather than with the idea that these are necessarily bad data. As I say, legal professional reasons. What was emerging was this quite sort of distinct split at the time. We have our pessimist skeptical view. There's some very serious people who had this argument who kind of thought this was all a bit of a waste of time. They're saying, okay, clinical data, bad quality, bound to have issues. Clinicians are bad at data entry. They just are in comparison to an RA. It's just the nature of the beast. And the only way to improve the quality of clinical data is to influence and impact how data are entered in the first place. And believe me, there have been a lot of attempts to do this for reporting purposes within the NHS, normally just for management reasons, but also there are some examples of sort of the graveyard of failed endeavours is full of researchers as well trying to influence how clinical data are entered. To improve data quality, experience teaches us is simply not feasible. The optimist view, yeah, sure, clinical data, they do have a problem in terms of quality, but that's okay because they enter clinical data well, and that's what all we really want. And what we really need to focus on is not what people are entering into the record, not try to influence that, but we should be focusing more on ourselves and how we pull that data out. And if that is something that we can do, that is feasible, and that we think potentially is going to be fruitful. Put that another way. If you want to get good quality data out of a health record, you need to be focusing on how you pull it out, not really getting so much fussed on how it's being entered. Some simple examples of what that challenge looks like from a data point of view. You will find across, certainly psychiatric records, the same data can be entered in lots of different places for different reasons. Can be a difference in services. One CMHT may want to enter data here and they practice in a particular way, another CMHT practices in another way. Another reason may be because over time, these records last for a long time. You know, we've had our record for 10 or 15 years. Changes in practice, changes in research, etc., means they put data in, the same data in different places. If, for example, you wanted to pull out a BMI for a patient in the Maudsley record, there are 15 different there are 11 different structured fields where a BMI may be entered. And you'd have to look across all of those. In fact, one of them, I think it's this here, has 9 different fields just within that one form where a BMI is entered. So you end up with 19 or 20 different places where a BMI can be entered. Now, that's just not where they're entered. So in a nice database, you might expect all those results to go to one nice BMI table. Well, they don't. Electronic health records are more like electronic filing cabinets. So every single one of those in the back end is a separate table. You've got to open this drawer to get that one, this drawer, and you've got to put them all together. If you don't know that, you ain't going to get them. Add to that, if you then actually look in clinical text, look in those case notes, looking letters, etc., you find almost double the number of scores again in terms of just BMI, which leads to the second big challenge. From a technical point of view, clinicians prefer text. They certainly do within psychiatry, not just psychiatry, in acute medicine they do as well, but very much in psychiatry. That's the way people are trained. And as I've mentioned before, attempts to try and persuade nurses and doctors to stop using text and to start using checkboxes and dates doesn't work, hasn't worked. If someone could do it, great, but tends not to be successful. Those are the challenges from a data point of view, really the challenge in terms of sort of the mindset, if you like, of thinking that actually that to improve quality is down to us. It's down to us who are pulling out the data, or you who are using the data. It is an attitude. And the first thing you have to do is to really accept that these are health data. They are not research data. Just to an extent, you've got to really quite love that. You've got to enjoy the fact that it just in a few cases, it may well be that you see the same patient is on 2 different wards at the same time. Or maybe someone's first ever diagnosis was 20 years before they were born. Or it may just be that the checkbox says that this person smokes. But if you look in their case notes, it says 15 times they went out to have a cigarette, nipped out for a fag with John, as it were. If you don't enjoy that, then you may not quite enjoy working with clinical data. We're obviously using data for a secondary purpose. We've already made the case that clinical data are fine as long as you understand what the clinical purpose is. So if you can get your head around the primary purpose, for those of you, for example, who are not clinical people, there's no better way of understanding the data than to work with somebody who is, and to talk to people who understand what gets entered, why it gets entered, where it gets entered, what is reliable, what's not reliable, what does it mean when something's missing. And then it's up to us to use innovative techniques to pull that data out, which I'll come on to in a sec as sort of the main thing that we've done in that area. And then last, you've got to really know the data. I showed you that BMI can be recorded in our record, 19 different fields. That's actually something that most nurses, doctors, they wouldn't know that. How else would they know? They just know what they do. To give an idea of the scale of the challenge where we work at the Maudsley, for secondary services, there is one electronic health record, known as the electronic patient journey system. And that single electronic record covers a whole range of services, going from children through to adult psychiatry specialist services, older adults, everything in one place. Everywhere, they all practice slightly differently, use the record slightly differently. we've got nearly 11,000 data points in there. Now we know 20 of them are BMI, so that's a start. But you know, what are the other 10,920? You've got to get your head around those. On the other hand, to give in terms of sort of consistency within the data, out of all our instances, we've got about 80 million rows of data coming out of this record. About 65 million of them are just free text entries. So these are case notes and clinic letters. That gives you some idea of the kind of a balance, if you like, of the data within an electronic health record within psychiatry. Okay, let's go back to 2007 again, where we started. So it probably won't surprise you to know that we decided, despite the challenges, that we would accept the challenge and pursue our sort of endeavor to access clinical data for research. And we built what has become known as the CRIS system. This is our particular solution. For all the reasons that I've explained, we had an important prerequisite. Number one was, if this was going to work, we knew we had to be able to access clinical text. This was very unusual at the time within the NHS. I think it probably is still quite unusual, actually, because it can be tricky to work with. The other prerequisite, which was, if anything, more significant, which I'm going to touch on a little bit now, although probably not as much time as it deserves, truth be told, if this is going to work at all, this can only work if we do it in a way that protects the legal and ethical rights of patients. There's a tension. Obviously, what we want to do is we want to do stuff which is going to produce results which are going to have a sort of positive impact on the patient population, but there's a tension between that and the need to protect the rights of an individual patient in terms of access to their data. And that's what we needed to try and resolve. For that reason, I would always describe in what we've built, which, as I say, we've referred to as CRIS, fundamentally what it is it's a governance model. And you're going to have something equivalent to this anywhere if you want to access clinical data. A key requirement of that model is that we de-identify the data as we take it out of the health record and put it into our repositories. De-identification, that includes messing about a little bit with some structured data, but the main effort in that is de-identifying the text, which I've already said we need to pull in to CRIS. So we remove known patient identifiers, names, dates of birth, family members, etc., from that text. But I use the word de-identify advisedly, because what we don't do, what you can never do with health data, is you can never anonymize it. It is simply not possible. So if you start off with the ambition of saying we need to anonymize data, then you might as well give up at the beginning. It's just not possible. So that just becomes one of several really key headlines in this governance model. And the others are here. Let's start here. Anybody accessing the data needs to have project-specific approval. So there's no free rein to access data for anybody. It's only for a particular approved project. There are, in fact, for most of the projects we'll come on to again, we pull data out as a service for people rather than them pulling it out themselves. But there is a facility for people to access data themselves. And for that, we need to have an audit then of all direct access. We run a weekly check that compares what someone queried with what they said they would do. Any of the individuals accessing the data then need to have a contract or a contractual obligation with the NHS Trust. Basically, that makes them suable, makes them sackable. That's the same standard, obviously, you'd apply for anybody accessing clinical data at all. Any of you clinicians, you're all sackable. That's what gives you access to the data. And then any individual data which you pull out for analysis must remain within inside the secure NHS firewall. Patients have the right to opt out of having their data within CRIS. And for that to be meaningful, we have to have an active and effective communication plan, obviously to let people know that this system exists and what we're doing with it. And this whole model was developed by a dedicated and patient-led committee, and it's now managed and monitored and overseen by that committee. That's kind of it in a nutshell. I should say it's a little bit more complicated if you want to access data for recruitment purposes, because obviously then you've got to contact people and get back to them, but I'm not going to talk about that. If you're interested, I'm sure we could talk about it later, maybe after the end at the break. But there is more detail about the model, which we've published, if anybody's interested. Based on that model, we got important NHS approvals going back to 2007 again. So we need to have the approval of the NHS Trust. So we have what's called Caldicott approval, and then that gives us the approval of the executive within the trust. That then gives us research ethics for CRIS, or at least data as a database. And that's important because then now all the people who want to access these don't need their own project-specific approval. It's already covered. And that's now been adopted nationally, this model, as through a program called UK CRIS, in fact. I won't talk you through this, I promise. This is our technical infrastructure for those who are interested. We used to work with an engine called FAST. It was a sort of bit like Google, sort of enterprise search technology. That's because we were very much heavily focused on text, as I've said. So we thought, oh, well, it's text, we want to have a sort of Google type search thing. Turned out to be wrong. It was fine, it worked, but we've now switched entirely to SQL Server. Really, we work in SQL Server and we work in Azure. In short, I promise, backend, these are the database, this is our main electronic health record. There are other systems we access. These tend to be big, chaotic relational databases. So the first step in our process, which we run every 24 hours, is we take this big, chaotic, crazy thing and we turn it, we sort of denormalize it, meaning we flatten it out into sort of usable, meaningful tables. They're kind of similar to the interface that the clinician sees when they enter stuff in the record in the first place. Once we've done that, that's where we run our de-identification process, which takes out all those names, etc., from the text. We actually have two secondary processes, a data linkage service, which Amelia and Katrina are going to talk about this afternoon. We run text processing, which I'm going to talk about shortly. But otherwise, this database here, we have a sort of back window into it, which is where we write code for using SQL to pull data out for people. Or we do have a front-end application, which is a way in which researchers themselves can query the data directly and pull stuff out without having to write code. It's kind of helpful for looking at text in particular. I'm just going to show you a couple of screenshots of that just to give you an idea of what the data looked like. This was a search done searching for donepezil, as it happens, or use of the word donepezil in case notes. That's donepezil is an anti-dementia drug, and actually just the word Alzheimer. This is an example of what the output looks like. So you can see highlighted my term Alzheimer and my term donepezil. And here you see an example of the de-identification of the text. So there's all our first names, last names, address, date of birth taken out and replaced with Zs. I didn't choose that example randomly. I chose that because it was indicative of a search done very early on by someone called Guyan Pereira, who used CRIS for his PhD. Guyan is a bit of a legend where we are. I'll sort of explain why. What Guyan was interested in is he was interested in the decline in cognitive function for people with Alzheimer's as measured by something called the mini mental state exam score. The mini mental state exam is sort of like a memory test in effect. Scored out of 30. And obviously for people with Alzheimer's, that starts to get worse. And what he was interested in was how the use of anti-dementia drugs impact on that decline. And what he found for the population was that at the point at which that drug is initiated, you see an improvement. That improvement lasts for about 6 to 9 months, but then unfortunately it starts to decline again. This result was a very big deal. It wasn't a big deal, particularly in terms of its translational impact, in fact. But it was a big deal going back to this argument which I started with about our pessimists and our optimists, and can we use clinical data for research? And the reason why is because this was the first result that really gave the data coming out of the clinical record face validity, because this matches exactly what you see in all the trial data for the use of these drugs and how they affect this particular population. And that gave the data credibility. And suddenly these, well, I say suddenly, it was the start of some very senior people who really knew what they were talking about, suddenly going, actually, maybe these data do have some value. Maybe there's something we can do with them. They also demonstrated the power, which I mentioned in terms of size. This was, in fact, it was published in 2014, but actually Guyon did this work in early 2011, when there was about 3.5 to 4 years worth of data that was available. And even then, that was 5 times more than all the Cochrane Review data across the world combined, just for one mental health trust in Southeast London. But it also raised serious questions about feasibility of doing something like this at scale. Text search, which is, you've seen an example of it with the word donepezil and Alzheimer's, it is a powerful thing. And in fact, literally the very first study we did with Chris was a search on the phrase, "do not attempt to resuscitate." And they were looking for examples, there was no other way of finding them, for patients where that instruction had been given, and they wanted to check whether a particular policy had been followed. And the number of cases they found was something in the region of 100, 120, something like that. So they were pulled them back, and they were able to read through the text. And it was, again, in terms of the trust, the NHS trust had a big impact. They were like, wow, this is something we've never been able to do before. And text search is great if you want to find effectively a needle in a haystack, or 120 needles in a haystack. Problem with what Guyon had to do is he's finding literally thousands upon thousands of needles in a very, very, very large haystack. One of the reasons why Guyon is a legend is because he spent 6 to 9 months just reading and reading and reading all these snippets with donepezil and MMSE, and pulling out all these scores and generating all these episodes of medication in order to generate that result. So what we did is we started off on a path to extract information automatically out of text, or what is described as natural language processing, effectively trying to get a machine to do exactly what Guyon had done manually, to read through all that text, pull out these structured data. We didn't know what we were doing, but we knew someone who did. So we worked very closely with the computer science department at Sheffield University. They have, in fact, built something called GATE, which is an open source text mining or text engineering platform, which is what we have used and what we use now. Our initial use cases were based entirely on Guyon's work. So we were interested, can we pull out clinical diagnosis? Can we pull out pharmacotherapy? Believe it or not, in most mental health records, medication is only recorded in text. There's no electronic prescribing, at least very, very little electronic prescribing, in the community, almost nothing. And attempts to try and get doctors to fill out forms to say what medication the patient is on, not so much. So text is really the only source we have. Pharmacy dispensing system we have, but that's minimal. And then MMSE scores, which is obviously what Guyon needed as well. And this has been a really big deal for us, the building of NLP. We probably have now about 100, 120 different applications that give us structured data out of text. In terms of what it looks like, this is a very simple example of one case note where we've got a few things from those first use cases. So here's some snippet relating to diagnosis, got a diagnosis of moderate depressive episode and Alzheimer's. What then the NLP app produces is data that look like this. This is in a SQL database. So we've got our diagnosis there at the end, and that's pulled out by this machine. Similarly, when it comes to the medication, mentions of mirtazapine, and that's what the machine will find, and it will populate these various different fields in relation to dose, etc. And then an MMSE score again, there it is. That is a relatively easy thing to pull out. So we've got a score of 19 for numerator, and the denominator is given because it's not always completed, the MMSE, so the denominator is not always 30. So as I say, this was revolutionary for us, really kind of changed the world in terms of what we were able to do. But it would be a mistake to say that it's easy. NLP is not easy. And it's not easy because some entities are not very amenable to NLP. So there are some things we've tried to pull out and not been able to. It's just too difficult. The sort of linguistic and grammatical context is too difficult. But also it's not easy necessarily to use. And I would want to sort of focus now on a couple of things that I think the user needs to really understand about NLP if they want to be able to use the data well. Start with this one about understanding and then managing nuance. Structured data, which is what we're pulling out using NLP, is very alluring. There's nothing nicer than a 1 or a 0 or a date or a code or something like that. It's just lovely and straightforward, and you don't need to think too hard about it. You just use it. And the same is true, obviously, with structured data pulled out of text. And what you just implicitly assume when you look at structured data is kind of you're judging this, that if it says someone has a diagnosis of Alzheimer's, then it means they have a that's what we found. And if they don't have one, then it means they don't have one. It's nice and easy. For smoking, if I see a tick box that says that somebody smokes, yeah, they smoke 20 a day. And if they don't smoke, well, they don't smoke. Of course, in real life, that's not true. And in text, it's not true. One of the reasons clinicians prefer text is because it gives you the opportunity to reflect nuance in what you're reporting. So things are not black and white. What there are is lots of shades of grey, or shades of orange, in fact. These are all the kind of things that you find in text. So has a diagnosis of Alzheimer's? Yes, but maybe meets the criteria for a diagnosis of whatever. May meet the criteria of, before coming here, was diagnosed with, or says he was diagnosed with. Shows signs, and in fact, there's lots more than that. You can imagine all sorts of things before you get to does not have. And the same is true for smoking. Smokes 20 a day. Yes, you see lots of that. Smokes heavily when stressed. Is a committed social smoker. Is trying to quit, but finding it hard. Gave up smoking last month, doing well. Doesn't smoke. And again, you can think of, I mean, now with the introduction of things like e-cigarettes, actually, it's become that much more complicated. So what obviously you have to do is, if you're a human being coding data out of the text, you've got to come up with a place where you're going to set the bar. You know, you have to categorize. So you either categorize above the line or below the line. You can, you know, the line might come there if you want to be quite strict, or you might, if you want to be a bit looser, you might put it further down there. And the same is true, obviously, when you're teaching a machine to do this as well. So what's really important for you in terms of using these data is you have to know what the rules are that have been used to build the machine, whether they're very inclusive or whether they're very tight. I mean, I should say this applies to all data, all structured data, including structured data which are entered structured at the point of entry. So again, talking about that smoking, one of the, for those of us who work with text, one of the reasons we like text is at least we can see the nuance. If you just got a checkbox that says yes or no, you don't know how somebody's judged that. It's different for every person. There's no inter-rater reliability at all. It's just not possible. You just have to assume there's some consistency. But as I say, structured data is very alluring. So it's nice not to think about that and just think, well, it's just yes and no. The second thing that I really want to focus on in terms of understanding these data, in terms of how to actually use them, to use them well, is to do with performance. Now, obviously, as a human being, if you read through hundreds and hundreds and thousands of text snippets in order to try and code it, you're going to make mistakes. In fact, people do. Very often, the machine does better than the human being for that reason. So we can see that. But the machine obviously often gets it wrong too. So some things are easy to pull out, some things not so easy to pull out using NLP. So just a bit on performance of NLP. As you would probably expect, basic output is measured in two ways. We're looking at precision and recall as what you would sort of more commonly think of as specificity and sensitivity. So what's our accuracy rate of all the things that we're seeing? How often are they likely to actually be true? And of all the stuff that's there, how much do we tend to find? I'm just going to expand a little bit on that, even though perhaps it's a little obvious, but I think it's worth doing this. Do it through an example of an app we've recently started working on, trying to pull out what's being referred to as clinical trajectory. So clinical trajectory is whether or not there's evidence in the notes that someone is getting better or they're getting worse, basically. How are they doing? And we want to know whether that improvement is something which has happened from the past kind of up until now. That's what we're trying to pull out. It's some evidence of some kind of a clinical outcome. We're looking for trigger words, things like this. Generally, the most NLP generally works with trigger words or dictionaries, gazetteer lists they're often referred to. And you know, we're in the case of medication, you can imagine you have a list of every single medication in the universe, and you see if you can find it in the notes. And then you look at the, as I say, the linguistic and grammatical context, and you say, do we want it or don't we want it? So we use these kind of trigger words for the trajectories app. I made these up, I should say, but these are 4 kind of 4 bits of snippet, 4 text snippets that you might find in the notes that you would hope this app would look at, shall we say. Let's think of him as a person and think, yeah, these are potentially of interest. We take the first one. When he drinks, he feels much worse. That he feels much worse, you think, well, okay, that's a sign of things are getting worse, but obviously in this case, it's only when he drinks. So it's a conditional statement. In fact, we want the app to throw it away. That's not a sign that someone's getting better or worse. It's just a condition. He says things are on the up. That indicates that things are better than they were. So we would hope the app identifies that one. Sleeping is much improved. Clearly, that's an improvement in a symptom, which we're interested in. So we would hope that that is identified by our app. Her brother offered her a room, but she has declined. Well, it's got our trigger word declined, but in the wrong context. So we would hope the app throws that one away. Let's imagine this is in fact what the app actually did. So 1 means the app said, hooray, we want to keep this one. 0 means, no, go away, we don't like you. So in terms of our sort of performance measurement, when he drinks, he feels much worse. Well, the app has identified that as a trajectory, but we've said it's not, it's conditional. So that's obviously a false positive. He says things are on the up. Well, the app's not identified that one, even though we say it should. So that's a false negative. Sleeping is much improved. A 1, he got it right. Hooray, that's a true positive. Her brother offered her a room and she has declined. He didn't find it, or he threw it away. Good. So that's a true negative. In terms of our precision score, the proportion of positives that are correct, well, we got 1 true and we got 1 false. Therefore, it's 50%, 1/2. Recall rate of all those mentions that are in there that are relevant. How many did he find? Well, again, there were 2 that were in the text that we wanted him to find. He only found 1 of them. So recall rate of 50%. Okay, that's pretty obvious. But I wanted to highlight that because if you look at performance measurements of things like NLP, that's basically as far as they go. They'll sit and they'll give you these precision rates and recall rates or sensitivity, specificity, and you'll look at them and you'll think, that's good, that's not good enough, that's bad. And you'll decide and judge the data on the basis of that measurement. And it's not irrelevant at all, but it's not enough. Not enough with clinical data. It may be in other situations, but it's certainly not enough with clinical data. And here's some examples of why. Simple question. What was the BMI at point of admission? I can tell you the precision rate. We've seen lots of BMI scores in text, and the precision rate of our BMI app at score is 95%, which is pretty good. So someone says, okay, fine, I want to use that. And here's some examples of how it works. This is a very typical snippet. Assessment, BMI is this, blood pressure is that, and the app found a score of 22.15. Here's another one. Refused to be weighed. When last measured, BMI of 1605 was reported. We'll try to get up-to-date measure later in the week. 1605, good, well done, we got it correct. But obviously our question is, what was BMI at point of admission at a particular point in time? The first one, we got a date, and clearly the date of entry matches the date when the BMI was done. But clearly in the second one, the measure was done at some point in the past, but we don't know when. But the only date we've got is the date when it was entered. That makes it very difficult, obviously, to allocate a particular point in time to the score. And that's very common. And in fact, when you measure not just the score, but how well the score relates to the date of entry, you get a different level of precision. And in fact, for BMI, the score precision is 95, but of those 95%, only 80% of them are contemporary to the time of entry. And that's true with lots of the data that you might be interested in. Clinical records, people enter the same information loads of times. You know, patients have, there's a chronic care service, we've got patients who've got 2, 3, 4, 5, 6,000 different case notes. So you'll see stuff entered historically and can just loads of times. You want to know, I mean, this is interesting here. We've been doing some testing recently on stuff specifically around psychotropics. And we found that the precision rate of the app when it finds a dose and it links it to a particular drug is very, very, well, it's 100%. It's very rare, and so rare that it's kind of irrelevant in terms of the count, that you'd find a drug with a dose where the patient is not on it. In other words, it's not a false positive. But still, obviously what you want to know with drugs is, are they on it at a particular time? And the date makes a difference. So the contemporaneousness is still not perfect. That's, as I say, the case with loads of data. How are we doing? What am I? 5 minutes. Okay, I'll go very fast, 5 minutes. Here's another quick example. Very quick example. What proportion of a population have ever smoked cannabis? We have an NLP app that looks at cannabis use. Here are 5 examples of annotations that were found and identified as positives by the app. Zed smoked a lot of cannabis when he was younger. Correct, well done, the app. Zed felt she had to move out because she was smoking cannabis in the flat. Well, obviously that's not the patient smoking, so that would be wrong. He said he's been arrested several times for possession of weed. Good. Smokes up to 5 joints a day. Yes, good. Smokes less cannabis than he did. Good. So that's what we would score. 4 out of 5 are correct. Precision rate of 80%. But as I say, lots of stuff is entered lots of times for the same patient. So imagine if actually, there's our patient IDs. The 4 true all come from the same patient, and the 1 false comes from a different patient. So in terms of a population, whilst 80% of the output is correct, we've only identified 2 patients, and 1 of them has been identified incorrectly. So at patient level, our precision rate is only 50%. That's probably the biggest mistake people make with these data, is that difference. That you measure something, it looks great, 95%. Clinical records, people enter stuff that's true. They don't tend to enter stuff that's less true. So people who smoke, it'll be mentioned hundreds of times in their record. So it's much easier to find than if it's mentioned only once or twice, which might be the case for people who don't smoke, for example. I'm nearly finished, I promise. So this is the precision of our app that identifies diagnosis specifically for schizophrenia. We happen to have identifying people under the age of 18 with schizophrenia is tricky. They don't tend to write it in structured data. So we had someone from a child and adolescent psychiatrist saying, that's fantastic. Can we use that to identify people under 18 with a diagnosis of schizophrenia? We said, yep. And they said, oh, how does it work? Can you show us some examples? We said, yep. So we said, okay, we'll show you some examples of what the app has done. This is the first one we showed them. Mother was discharged in 2013 with a diagnosis of paranoid schizophrenia. Oh, sorry, not that one. We'll move on to another one. He has a first-degree relative with a diagnosis. Oh, sorry, not that one. We'll move on to another one. Her bro has a diagnosis. All right, okay, not that one. Menela, discuss working diagnosis of schizophrenia, which Zed does not agree. Those were the first 4 that we showed this person. So it's slightly embarrassing. Turns out in CAMS records, specifically, schizophrenia is not mentioned very often, and when it is, it's nearly always somebody else in the family. So whilst brilliant precision rate for adults, child and adolescent psychiatry precision was less than 50%. So again, you've got to be really careful. Fat millions, 60, 70 million, as I say, text documents for all different services, and performance is not common across. You've got to think very carefully about how you're using it and where you're using it, and that affects performance. We've looked at temporality, patient versus instance service. There are other ways in which performance can vary. That's kind of me done, hooray. In summary, I'm going to hand you over to Amelia in a sec, who's going to carry on this story. What I've been looking at, we've touched a little bit on security, but actually, if there's any single take-home message, it should be that, really. You must have an effective security model to access clinical data for research. The quality is questionable, no doubt about it, but it can be good enough. But it's very much up to you, and it's up to people like us to accept it and to embrace it and to like it and to enjoy it and to understand it, and then to use innovative techniques to pull information out of that. It is not some patient census. And lastly, quality is not a tangible thing as such. The quality that it relies just as much on us and how we look at it and how we understand it and how we interpret it and apply it as it does. It is inherent to the data themselves. I'm now going to hand you over to Amelia, who's going to sort of carry on with this, considering how you can optimize accuracy by using appropriate definitions, and make sure you have definitions which are appropriate to the question you're asking. And accuracy is very often contingent upon that. Amelia is going to be looking at sort of complex entities. To give a final example of what we mean at a very simple level, this is a very commonly asked question, not particularly for us, but in an NHS trust. And I see this being asked within South London Maudsley very often by non-executive directors or service managers. And I've also seen all 3 of these answers given, from 48,000 right down to 28,000. And that is a massive difference in terms of how many active patients there are. It makes people cross, and they say, well, how can it be that different? You don't know what you're doing. And then they say, which one's correct? And obviously, The reason they're different is because they're defined differently. So the first one is defined as all patients who SLAM has received a referral for and said, yep, in theory, we're going to take you on. So we'll accept you. But they haven't been put onto a caseload yet. The second one is the number of patients who've been accepted, and then a team has said, fine, we'll accept you, and now we're actually going to add you to our specific caseload. The third one is then not people who've been accepted to the caseload, they've actually now been seen. They've been seen at least once, hence the big difference. So in terms of which is correct, obviously, depends on the question that you're asking. And you've got to use the right definition for the right question. If I was interested in unmet need, I might choose the top one. That tells me how many patients are being referred. Second one might tell me something about service capacity. Now, how many patients teams are prepared to take on. Interesting, you see over the last however long, that middle figure has stayed very, very static for many, many years. That figure on the left just goes up, 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 up. And you see that particularly the last 6 or 7 years. Anyway, third one might be more relevant if you're interested in investigating some kind of the impact of or some kind of intervention, for example, or how many patients receive CBT. Your denominator is obviously only going to be patients who've actually been seen. There's no point including patients who haven't. Most important thing, the definition and matching the right definition to the right question has a massive impact on accuracy. So the accuracy is not just in the data, but it's in how you use them. I'll pass you over to Amelia.
Thank you, Matthew. So I'm now going to talk about how we can turn this research or this clinical data into an actual research data set. And I'm going to do that by taking you through an example of a question that a team came to us with that they wanted to answer using CRIS. To start with our questions, this is a clinical team and who had set up a new psychological therapy service that was aimed at patients who self-harm. They had a couple of questions. They wanted to know who presents to this service and was their service effective? And within this, they had some specific requirements. So first off, they wanted to use the data to identify patients who attended the service. Then they wanted to know who they were. So their demographics, some basic demographics, gender, ethnicity, age, deprivation scores related to their address, and their mental health diagnosis. They then had 2 outcomes that they were specifically interested in. So this first one, this HONOS score, Health of the Nation Outcome Scales. And they were interested in the HONOS score when the person first joined the service, and then what their HONOS score was at the end of their time with the service, and in the hope that what they were going to see was an improvement in this score. The second outcome they were interested in was A&E attendances. These are patients who self-harm, who have regular attendances at A&E. And they wanted to know how many attendances they had prior to being accepted to the service, and then the number that they had after being discharged, with the hope again that they were going to see a decrease in the number of attendances. So they came to us, and these are clinicians who work in this service, who work with these patients, and they had an idea of what the data should look like in their heads. So if we look at our timeline, and a patient comes into SLAM, their demographics are recorded and address is taken. They're then given a diagnosis and they're referred to the service, and they have this episode with the service. They have a HONOS score, which is recorded at the beginning of their time with the service and again at the end. And they will have also had a number of A&E attendances prior to coming to the service, and then potentially they may have had some afterwards as well. And this is what they were expecting the data to look like based on their own experience of working in the service. So then it was our job to turn this into kind of a data extraction specification. So this is our specification. This is our spreadsheet. Each of these columns is going to be a header within our data. So first up, identify the patients who attended the service. We have this episode. So our inclusion criteria for our cohort is patients who attended the service, and we have our start and end date added to our specification. And in our data here, each row is going to be one unique patient. We want to know who they were, so their demographics, their address, their diagnoses. So we can add these into our spec. And then our outcomes, so our HONOS score at the beginning, our HONOS score at the end. And then our A&E attendances. We had a number that occurred before and one that occurred after, and we can add in a count of these. So a count that occurred before being referred and then the count that occurred after. And this was their specification. But actually, when we started digging into the data, what we saw was a bit different to what they were expecting. So let's start with our very first requirement, to bring people into our cohort. So identify patients who attended. And what they found, and they were quite surprised by, was actually patients didn't just have this one episode. There were many patients who had multiple episodes with the service. And so they weren't expecting this, and they thought, well, actually, from experience, we know that some patients drop out. They might then rejoin when they're feeling a bit more up to doing it, and they might then have a second episode. So then there was this question, well, which one are we interested in? So you could take the first episode and actually thought, well, if patients are dropping out, then we're not interested in that one because the patient's dropped out, they've not completed. So maybe we should take the last one. But when we looked at the data, what we saw was that in some cases, there was these short episodes followed by the long one. But in other cases, patients were having long episodes with the service, a break, and then a shorter episode. So, well, maybe we'll just take the longest one. Or maybe we should just take all of them. And actually, there's no right answer. As Matthew said, the decision is going to depend entirely on what the research question is and how that team operates. So actually, in the case of this study, what they decided is they were going to take all of the episodes. And so what we have here is this changes the currency of our data set. So we're no longer working with a patient level data set. Instead, each of our rows is going to represent a team episode, which means that where a patient has more than one episode with the team, that patient's going to appear multiple times within our data. So moving on to who they were. So let's focus initially on the demographics. So a patient has their demographics when they're first referred to SLAM, that's recorded when their record is created. So we can add in our gender, our ethnicity, and our age. But of course, age isn't a static variable. So, and this question is going to come up a lot. There's a bit of a theme. Age when? So again, we could take the age today. We could take the age when they were referred. And there's no right answer. Again, that's really going to depend on what you're interested in. And in this situation, they decided that they were actually interested in the age the patient was at the start of the episode. And what we can start to see here is that although we've got the same patient who's appearing multiple times within the data set, they're going to have different data at each row. So moving on to deprivation, we saw in our kind of perfect timeline, we had the one address that was recorded for the entire time the patient was with the trust. But in reality, people move around. We may have gaps in addresses where we have no active address recorded. We may have situations where there are multiple active addresses at one time. In the example we've got here, we've got an initial address, and then we've got a gap with no address, and then one for a shorter time and followed very quickly by another address. So which one do we want the deprivation score for? And in the case of this study, they decided that they were interested in the address that was active at the start of the episode. So again, we've got another example here where we've got the same patient who's going to have 3 different deprivation scores for the different addresses that they had at each episode. And then our diagnosis. So diagnosis is a mandatory form within SLAM. Clinicians are required to input diagnoses for patients at various different stages. But what might happen is there might not be a concrete diagnosis given yet. So what we might see in the data is things like this. F99, mental disorder not otherwise specified. The patient then may spend a bit more time with the trust, and they're given a diagnosis. And that diagnosis can remain stable, or it can change. And patients can have multiple different diagnoses throughout their time with SLAM. So again, we've got the situation of which one are we interested in? Now, again, there are lots of different options here, and none of them are particularly better than another. In the case of this team, what they decided was that they were interested in the diagnosis that was closest to the episode start. But what they weren't interested in were these kind of placeholder diagnoses, these F99s. So then we have a slightly different situation when we remove those. We have a stable diagnosis for the first 2 episodes, and then we can see we have a different diagnosis for our third. And we can put those into our spec. So the closest diagnosis to the episode start, excluding this F99. So if we just look back at our requirements, so we've identified our patients. We've got information on who they are, their demographics, their deprivation score, and their diagnosis. So we'll have a look now at the outcomes, so this HONOS score. So if you remember, our clinicians wanted the HONOS score at the beginning of the episode and the HONOS score at the end of the episode. And now, I sound like a broken record now, but of course the data is not as clean as we were expecting. We don't just have this HONOS score given at the beginning and one again given at the end. So they decided in this case, we'll just take the one that's closest to the start and the one that's closest to the end and get rid of the ones we're not interested in. And what we can see happening here is we have this HONOS score we see between episodes 2 and 3 that is acting as our end HONOS score for episode 2, but our start score for episode 3. And there are little situations like that that will crop up in the data. And it's important to just be aware of them so that you can control for them in your analysis, or just make sure that you can just be aware of them and make sure that you can control for them. So for example, in this case, you might choose to control for the number of previous episodes that somebody's had with the service. And then next up was our A&E attendances, so the number occurred prior and the number that occurred after being discharged. So we have some A&E attendances, and we can see actually what happens is that some patients end up having attendances during their episodes. We can also see actually, do we want to include every single A&E attendance that someone's had prior to joining the service? So actually what will happen here is that someone's going to have a lot less attendances prior to episode 1 than they are for episode 3. So in this case, the team decided they were going to put in a time frame. We're going to count the number of A&E attendances in the 12 months before and during the episode, and we were going to compare that to the number that occurred in the 12 months after the episode. So if we think back to our perfect timeline that we had, and then our reality. But actually, after putting in these definitions, after looking at the data, after finding these quirks, we've separated that out into 3 much cleaner episodes. And then we have our final specification. Now, this specification can then be shared with the team who are extracting the data, and it can also be used for when it comes to writing up publications to detail how you defined each of your variables. And the take-home message is that, as we've seen, data are noisy and messy, but it is possible to use them for research. And you just have to be flexible and concentrate on the definitions. And I've got just some examples now of studies that have used CRIS. So here's this first one, which looked at real-time monitoring of antipsychotic prescribing in patients with dementia. And this one came out, I think, a few years ago now. And then just another one here, looking at air pollution, which found that it was linked to more severe mental illness. So it is possible to use clinical data for good quality research. So we move on now and just think about how we can replicate our work across different sites. So different trusts, different GP surgeries, different hospitals will use different systems and will have different data schemas. So it's not possible for us to just share data, share at a data level. We can't just take our extraction specification and apply it in a different trust. Even if trusts are using the same system, people use forms in different ways, and we've already seen that just between teams. But all mental health systems will contain the same information, the same clinical entities. It just might be located in different places. So our solution: replicate at the specification level, not the data level. So we can take that specification we developed, we can give that to a team at a different trust, and they can apply those same definitions to their data. And I've got an example of how we've actually done this. So during the pandemic, SLAM led on some work looking at the changes in daily mental health service use and mortality. And the team at SLAM developed a specification for this, and that specification was shared with 9 other sites in order to pull together all the data from the different sites and have a look at all of this across all 10 sites. And this paper actually had impact at a national level. So it actually led to the COVID vaccination being prioritised for mental health patients. They were added to that vaccine priority list. So that's it from me. Does anyone have any questions for Matthew or I before we have a coffee break?
Smoking is the sort of the easiest answer in many ways. You think, well, you would assume you're much more likely to record the fact that someone smokes. Therefore, if you've got 30% of a population where there's just no reference at all to smoking, does that imply that that 30% don't smoke? And in many ways, the only answer to that is there's nothing in the data as such to tell you. So it's a question for clinicians, is what we would tend to throw that back about missing data and just say, well, why would a clinician not record that in the first place? Is it true that they're less likely to record it for people for whom the answer is no, and therefore missing equals no? But did you have a particular idea in mind in terms of how to search for something missing?
Yeah, it's something I think about in my own data. So
Yeah.
I think you have somebody who's seen repeated times, so there's evidence of their interacting with the function during the service,
Yeah.
but there is no record of them smoking. In my head, I have more confidence that person is probably not a smoker because they're seen, usually if they're never seen, I think
Yep.
you have very little, they have little contact, then you can be less confident. It's just that it's no contact, so it's a genuine.
Yep.
Don't know.
Yep. No, I think you're absolutely right. And so that denominator as to how often someone's seen is very significant. We will find, for example, that the performance rate of smoking data is much higher for patients who are when they're on an inpatient ward than it is in the community, because for smokers in particular, there's every single day, there's normally some kind of a reference to the fact that they smoke. So for somebody who's on a ward for 2 or 3 months, if there's no reference to smoking at all, the denominator figure, where there's so many case notes being entered all the time, is generally a much more trustworthy thing. So it's much easier to interpret no as meaning no, or at least missing meaning no in that situation. But I mean, in my view, you have to do exactly what you've done, which is take the context into account. You still can never find the evidence of what missing really means. You just need to understand the data. It all comes down to understanding this primary purpose and what clinicians do on a day-to-day basis, I think.
So this team didn't look at that, but there have been teams that have looked at symptoms and kind of building up kind of profiles of symptoms. And actually we have 20 odd NLP apps for various different symptoms that can be combined to create these different symptom profiles. So yeah, it is something that some teams choose to look at. But again, it is down to just the individual researcher, what meets their requirements for their study.
Symptoms are tricky. That's interesting. Symptoms are one of those things that is very subject to error around temporality, because very often past symptoms are being reported, that somebody over time has, in the past they had this. Or if you have some big discharge summary, it may well be that people talk about symptoms somebody had at point of admission, which have now improved. So using symptoms to assess outcome as an individual piece of data is quite tricky. And what people tend to do is they group them all together and look for symptom profiles within certain periods. And it's kind of similar to the missing. You've got to start to interpret the variation over time and looking at patterns rather than just taking individual items and sort of using them that way. But it's certainly something that people do, is to look at symptom profiles.
So in this study, that was actually done with linkage to A&E data, which we'll talk about this afternoon a bit. It depends really. I mean, if you've got inpatients who are going to A&E, then that obviously is going to be recorded, but obviously not so much with community patients.
Depends on the reason for the A&E visit. So the mental health teams exist in A&E, and they would enter stuff into the Maudsley Health Record. So these liaison services would pick up. If someone goes to A&E and is not seen by the liaison team, then it wouldn't be recorded in our record. Then you'd have to have the linkage. Not to search, but to extract. Yeah. So if you think that what all these things have in common, these different mental health trusts, is not the record, as you say, but it's the practice, it's the primary purpose, it's the information that's being entered into the record. And if you want to be able to join data from different systems, as Amelia was describing, what you need is to define entities. And you pull out entities based on a specific definition. How you pull that out is going to vary from place to place. It depends upon the record and what the structure is, and what diagnosis table they have, or what events table they have, or what episode table they have, and whether they do stuff episodically or they do stuff will change from place to place. But the core primary entity is going to always be the same. I mean, clinical entities will be the same. So you have to translate the specification into something which is relevant for that particular record. But it's the specification, the entity definition, that produces commonality across different sites. I mean, there are certain things which will be common. I mean, in most mental health trusts are required to, for example, to report to something called the Mental Health Minimum Data Set, or used to be called that, so it changed its name. They will have some core entities around, for example, episodes, which will be the same, and those will be easy to apply across all different mental health records. Otherwise, the other thing that every trust will have in common generally is text. So the ability to run text mining or NLP will always produce a standard schema, which can be applied across different trusts. But the main take-home message of in terms of doing stuff on multi-sites is don't think you can just apply code and pull exactly the same data out in the same way. It ain't going to work. What you've got to do is just think in terms of entities and how do you reflect that entity in that data set. And as long as the definition of the entity is the same, then you should be able to produce the same analysis. We've never actually, what we've never tried to do, we've done lots of multi-site studies, is try to federate data. What we tend to do is actually just say, well, you produce that specification, each trust will extract the data based on their own particular schema, then they will analyze it locally, and then you compare results, rather than trying to create some big multiple data set where you're going to have these kind of problems.
It's also better for data protection because each trust will have oversight.
Yeah, one of the things UK tried to do, UK, Chris, was to produce a model where you could try and federate data, but federating data also, as Katrina says, for data protection is not it's a tricky thing to do. So absolutely, yes, and it's will be quite commonly done, something like that. So putting in things like number of bed days in a certain period, or how long someone's been active for a certain period, or how much history they've had in terms of contacts would be very common and very relevant in order to predict for those kind of things. I mean, essentially, the records are massive. I mean, and as soon as we start bringing in linked data as well, the amount of data can be kind of quite overwhelming. And actually, what you've got to do is really think, how do you utilize these data in a way which is not just going to swamp you, but to be able to do the kind of thing that you're doing. The specification phase, the defining of what you want to put out, is the key to using these data, because it's just so big in terms of what's in there. But the short answer is yes.
I'm going to hand over to Dr. Risha Govind, who did her PhD in health informatics using data from CRIS. She now works in the CRIS team as a senior informatician. So she works with researchers to help extract data from the clinical record. I'm going to hand over to her now, and she's going to take a practical session. Thank you.
Okay, so I'll be taking you on a real life journey of conceptualizing a research question, designing a study, and building a CRIS spec. So about me, I have a PhD in health informatics. My PhD was on investigating the effects of clozapine use using electronic health records. And all my analytical chapters were based on CRIS data. The last 2 chapters was on studying the association between clozapine and increased risk of COVID-19 infection. And this session will be based on these last 2 chapters. So indeed, this means that this session is very specific to a niche area of study, but I'll try to keep it general so you get a flavor on how to build a CRIS spec. This is the agenda for today. We'll start with the introduction for this research question, and then we'll design a study together and build the specs. Depends on how it goes. We could also build the specs based on the paper that I published. And I'll end with anecdotes of the expectations versus realities of this journey. Okay, so quick introduction. Clozapine is the only clinically proven medication for treatment-resistant schizophrenia. Treatment-resistant schizophrenia patients, they do not respond to any other antipsychotic medication. But unfortunately, clozapine is not without side effects. Side effects includes increased risk of pneumonia, and clozapine is associated with reduced immunity. But the benefits outweigh the risk. So clozapine is still being prescribed under rigorous monitoring. So, okay, so now let's go on a journey. Imagine it's horrid and it's April 2020. There's a pandemic, we are in a lockdown. There's a lot of questions. And some of the main questions are, who are at risk? Are there people of certain age groups, of certain demographics, of certain illnesses? My question as a clozapine researcher was, what about patients who are on a medication that increases your risk of pneumonia and reduces your immunity? So does the benefit of taking clozapine still outweigh the risk? So with this question, the first place we went to is, where do I find data? Where do I find data that is real time on COVID-19 infection? On a pandemic that's only been around for a few weeks, there is no pre-existing databases for this. So yes, this is the great advantage of using electronic health records. It is real time. But there's one thing you need to remember when using data from electronic health records. This is not primary data. By that, I mean, when in the model, when we use primary data, is you come up with a research question, you collect data that is specific to your question, and then you test your hypothesis, you publish. CRIS is a secondary data, which means this is collected by someone else other than the researcher who's doing the study. So when you work with secondary data, right up there with your research question, it's important to think about what data is available. And when, instead of collecting data, you'll have a much shorter journey of selecting the data to use, but this is important. And it is important to invest time in building the specs, in going through what is available, and also thinking of, in terms of doing a good study, I need to cast the net narrow to where I can build a solid model, a solid data set that can fit my question. Okay, so this is the study design. So we're going to build the specs for a case control study. So the question is, does clozapine treatment increase the risk of COVID-19 infection? So this means our outcome variable is COVID-19. So in terms of, and our cases and controls are patients who are on clozapine, patients who are not on clozapine. So this is a very general case control study design. And we start with a population. We split the population into our two groups, cases and controls. And within them, we look at the ratio of the outcome within each of the groups. And another important thing when thinking about using electronic health records data is the study window. Because this is data that has been around for decades. So if your cases are, I want all patients on clozapine, then Amelia will ask you, what about patient who was on clozapine 10 years ago, but we have no recent records? And if your question is, does clozapine treatment increase the risk of COVID-19 infection, then you probably need something more recent. So building a study window, and this is part of me as a researcher, I had to come up with those answers. What is my window? And together with someone who works in CRIS, we build the specs. So so I think we will form groups. You can form groups amongst yourself, probably per table sounds good, but what works for you? And let's think about this part. Let's build our two groups of cases and controls. How would you think of the inclusion criteria? Who will be your cases? Let's work with cases first. Who will be your cases? How would you define that? and I'll give you 5 minutes to discuss amongst yourselves, and then we can move on to the controls. How does it sound? Can I clarify one thing? In terms of time, this is, so the time is May 2020. So we would think we are in the beginning of the pandemic. And how will you design this? Okay, let's do the controls now, and then if you need more time, we can do that as well. So I think the important thing of thinking of controls is, because we work with electronic health records data, we can't just say everyone who's not on clozapine, because we're talking about 400,000 patients. So that's the thing of casting the net narrow, so that there's no imbalance in your two groups. but I guess this is the first step. I guess if we also remember about the time variables, this is the first step of the inclusion criteria. And when I did the extraction, we had a column for record of clozapine levels, and we found that there were very little data on this, and also recent data. And this meant that our groups will be becoming quite small. So I think, once again, going back to what's available, the feasibility of something so solid was not available. Matching by location is a good point, actually, which we didn't do. I think we accepted the fact that SLAM covers this the 4 boroughs of London, and that was sufficient for us. So I think this goes back to designing a study. If you were designing a study, we could do 2 extractions. One extraction, 1 table for your cases, 1 table for your controls, and then you can do your statistical analysis. We went for 1 table, and there was a column for on clozapine and not, and our inclusion criteria was the same for both. And there is no. It all goes down to the researcher and how they design the study. So I'll then go on to the next slide. Yes. Okay. So this is when we are building the specs. This is the sort of 4 things we think about. Who? So this will be inclusion criteria. In my case, we went with patients who have a schizophrenia diagnosis, and the 2 groups were those who were on clozapine, and the controls we used was those who are on any other antipsychotic. And our justification was, if my question is clozapine treatment, does the clozapine treatment increase the risk of COVID? Then if we were to take them off clozapine, they would be on another antipsychotic. So that became our control group. And so we compared active patients over the 3 months who were either on clozapine against on any other antipsychotic. But that was just the way I thought about this. And then another important thing is when do I want the data from? So we had an index date, which was the end of the 3-month period. So we went from 1st December to 1st March. And the reason we chose those dates was it was in mid-March that we had the first COVID case in the trust. So the patient should have been on clozapine or any other antipsychotic over that time, and the index date became 1st of March. But that was just our study design. Okay, so now we go down to the next part, what and how, which means what are the other variables that you need to control for? And the great thing about using electronic health records is there's so many things, so many variables. As a PhD student, it's like in a candy store, this and this and this. and my supervisor made me build a more complex specs than what we normally do at CRIS. Is for each variable, I needed to justify why. So I was like, okay, this is a confounding variable. This is for my validation. And that was hard because I just wanted everything. But I appreciate the importance, because if you think in terms of your study design, what really you want to control for, you can build a solid study. And how is important. What format do you want your variables in? What are the boundaries? And like Amelia was talking about, how do you want each variable to be? Do you want your antipsychotic based on this date or this date? And so that's what we will do next. So this is what a CRIS spec actually looks like. This is a template. We have the dates. And it could be your observation period, or the jargons would differ based on your study. But as far as our extraction is, start and the end dates of the extraction. We have the currency. What does each row represent? For our case, we were working on each row was a patient. So then the groups we were comparing were patient groups, but they could, other projects could have different currencies. The inclusion criteria was schizophrenia patients who were either on clozapine or antipsychotic. The index date was the 1st of March. And then this takes time, this part. What are the other things we need? So I have filled in for you the 3 easy ones. You want date of birth, gender, ethnicity. Also want, as you go further, you might want descriptions. Just Amelia had in her specs. What do you mean when you mean if there was age on which date? So that goes here. And the data type is, what is the format you want this? This will be a date, categorical variables, age is numeric, or sometimes you also want age in categories, which age groups they belong to. Okay, so this is our second part of the practical. We will focus on the what and the how. And I think if you Google for CRIS NLP, you can find this document. So don't go there if you don't, I didn't really consult the document. It has like all the different apps there is, but for fun, it's fun. This is the question. These are the 2 variables we've already had, clozapine status, COVID status. And if you're really stuck, you can see my paper. This? Yes, so sometimes per variable, we can have different dates. For this variable, this is...
You might want to search the entire record to find the ethnic minority.
And
search the whole one, wouldn't you, potentially?
Mm-hmm.
And the gender, and for the date of birth.
Yeah.
And that's fine.
That's fine. Because we can even say that this variable will be outside the window. And some studies, they don't go with windows ever until the date of query. Just a clarification, we are only doing the what and the hows right now. So think in terms of confounding variables. And you can think in terms of like things you read on the news, that these extra comorbidities, they had a higher risk of COVID. And what you in your project would like to control for is, in case we do see a hazard ratio in the clozapine group, it's not because that group was biased towards something. So what are the variables you'll control for? So this will be date, and there is no issues with this definition. BMI, numerical, and in terms of time, when? How would you last available? So last available based on we're extracting data in mid-May, and our study window with our index date we decided was 1st of March, because that was before the first COVID infection in the trust. So would you want BMI to be around the 1st of March date or the date of extraction? So closest, earliest to the index date? So that's our definition. And I think I had something similar. So for IMD score, probably if there are several that is the deprivation score, will probably the same how? Closest and before your index date. And IMD scores are numeric, right? Any more variables? Brilliant. That was the sort of variable I was after, because next question will be, what underlying variables? And do you want them, how would you want that column in your data set to look like? Do you want a different column for each variable? Do you want this to be some kind of an intensity score out of these X number of underlying variables? How many does this patient have? How would you like that data to be presented? So this variable is more shielding status.
Yeah, or just underlying.
So if this is May 2020, how would we find that data? So in terms of what we'll have in CRIS, we might probably need to see if those letters have come across to our health records. And they were not. So then I guess the alternative would be for the researcher to build a list of these illnesses that could lead to shielding, and then say, so I guess I will say here, a researcher will provide a list of diseases as a proxy for shielding. If I can spell it. Okay. And then I'll mark this into red. And probably I'll call this shielding proxy. Some kind of. And then this will be kind of a binary, yes, no. If they qualified, but we will have to come back to this. I guess that's so usually the first PACS meetings, we sometimes have a to-do list. So then you'll give us a list of medications to go through. Or would you like a column for every medication? Just could be, that could just go, like maybe it's a diabetes medication or the type of medication, antipsychotic, antidepressants. Yeah. And the advantage of that is then when you take this data to your statistical tool, then you can combine them if we give you more columns. Indeed. And one thing I didn't mention about in the introduction is clozapine patients are under rigorous blood test monitoring. So they get seen by the services often. So what we need to control for is that our control groups are also being seen, because we could lose the COVID status just by not not seeing them, or COVID patients would get tested more because they're seeing more. So controlling for those. So I'm going to show you what my specs look like. This was my specs. I had my window and my currency, and the index date. But usually we don't have the short and long descriptions, but I needed them for myself. Well, another thing was our COVID data was coming from different places. We were linked to King's College hospital system, which was coming from there. We also had COVID alerts in the SLAM system. So I was sort of trying to capture the different COVID dates. I was also looking at when we were tested, the data first test and the data first COVID positive. And other things that I was looking at is the diagnosis. Someone said DEPL, the BMI, inpatient dates. And here we were talking about the clozapine concentration in the blood. So we had that variable, which that column had a lot of missing values. I was trying to control for alcohol use and opiates, which, there were not enough data for me to use them in the analysis. 6,000 patients. I think of them we had 1,000 on clozapine, 1,000 something on clozapine. Yes. This was the list of variables that I actually first took to Chris. So we got, this is the inclusion variables, these nice demographics, and this was to make sure that clozapine patients are not seen too often. Unfortunately, in reality, back in 2020, our asthma and bronchitis apps were not really, they were in development. And I had a choice to either go to the clinical notes and read manually, but in the interest of time, and I wanted to get this paper out, I only worked with the confounders that was easily accessible, but I read the notes for the next paper. And then some funny things were happening. I was going to Matthew saying active on SLAM during index date, and he was like, what do you mean by active? Is it the referral date? And is it on caseload? And it took me a moment to see that, no, I actually want patients who were being seen. So the third category from his slides, because I'm looking at treatment, clozapine treatment. So I'd like, and based on this variable, that making sure my patients are seen, they needed to, my definition of active was to be seen. Taking antipsychotic medication was also an important way to think in terms of how do I define that? Because we have the prescription data, we have the NLP data, but that tells us there is a positive mention of an antipsychotic on this date, but we don't get clozapine start and end dates or any other medication start and end dates. So for me, I had to think in terms of, so my definition was from the NLP apps, there are positive mentions in the 3-month window. And that would be my proxy for the medication was taken. These are the two papers. 6,000 patients, 100 up to 2 tested for COVID. And since we saw a hazard ratio that clozapine treatment seemed to be associated with the risk of COVID, just getting COVID, then we did a follow-up study to look at severe outcomes of COVID-19 infection, and we didn't see association there. That was hard to publish. Okay, this is just not backup slides, but I wrote a really big part of my discussion of my thesis on this.
Oh, did you look at that?
No, what that I should have done.
I was waiting to tell me.
I think we're going to break for lunch now, 45 minutes. So we're going to start this afternoon talking about data linkage. I'm just going to do half an hour kind of brief overview introduction before handing over to Dr. Katrina Davies, who's going to take you through kind of her experience of using linked data in research. So as part of my role, I manage the SLAM clinical data linkage service. And what we do is we work with researchers to do data linkages with the CRIS mental health data. So we'll support them in their approvals. We will facilitate linkages. So either that's sending SLAM patient identifiers out to other organizations like NHS Digital, or we sometimes do data linkages in-house ourselves. And then we provide a hosting service for data, and we also provide a data extraction service. So we talked about this morning with the specifications, we help people develop specifications using linked data. So I just want to start by going back to this paper, which was quite an early output from CRIS, looking at life expectancy at birth for people with various mental illnesses. And you can see here we have the UK norm in our first column, separated by males and females. And then we have the life expectancy for people with various mental illnesses. So we've got schizophrenia, bipolar, depression. And what you can see is that the life expectancy is an awful lot lower for people with a mental illness. And actually, on average, it was found to be about 20 years lower than the UK average. And this paper had some quite big impacts. So at a local level, it led to SLAM introducing their smoke-free policy. So smoking was banned on all SLAM sites and within wards. And they introduced smoking cessation services for patients. There was also an increased clinical emphasis on physical health assessment, and mandatory forms were brought in which required clinicians to record things like BMI more regularly for their patients. At a national level, it also led to a recommendation in policy for funding for mental health services to be on par with physical health services. But it also led to a lot of questions. So specifically, what were people dying of? And why were they dying earlier? And was this because they were being diagnosed with physical conditions like cancer later than people without mental illness? Or are there differences in the treatment received by people with mental health diagnoses? But the difficulty is, and you might have already talked about this a little bit on your tables, is that physical health information is not very well recorded, if at all, in the mental health record. So if there's a patient who is also receiving treatment for cancer, it's very unlikely that information about their treatment plan or their diagnoses is going to be written within the mental health record. So the solution is data linkage. We need to link to another data set that's going to contain that information so we can find that out about our patients. So what is data linkage? So very simply, it's the joining of information from two or more different sources that relate to the same individual, family, place, or event. And those sources must share identifying information at an individual record level. So for example, a GP record, hospital record will both contain an NHS number, which is unique to that person. So the team at SLAM decided they were going to link the mental health data from SLAM with physical health data from hospital episode statistics. Now, I'm sure most of you are familiar with the HES data, but that's data from acute hospitals and some mental health data from the whole of England and Wales. And that data is held by NHS England, formerly NHS Digital. But data linkage is a challenge. It's a technical challenge, but it's mostly a governance challenge. If you want to use data from any organization, the first step is you need approval from their data controller. And that's the person or the organization who determine the purposes and the means by which personal data is processed. And whenever you approach a data controller with any kind of project like this, they're going to have this question at the forefront of their mind. What is in the best interests of the patients whilst also protecting their legal and ethical rights? And it's a balance. So if we think back to this paper, we can see that if we can work out what is causing this mortality gap, and we can potentially put in interventions to reduce it, which has obviously got massive benefits to patients. So it's clear that this work will have benefits. But we need to think about how we can protect their legal and ethical rights. So there are a number of statutory approvals. And first off, let's thinking about the legal basis. What's your legal basis for doing this project? And that could be consent. So if you were to obtain individual consent from each patient to link their medical records, then that's sorted. But one of the benefits of using administrative data is the size. And actually, practically, you're not going to be able to consent 450,000 patients. Specifically, in the paper that I was talking about earlier, a number of your patients have already died, so it's physically impossible to gain consent. You're also potentially going to be introducing some bias. There's going to be differences between patients who choose to consent to their data being linked and those who don't, or those who you're not able to gain consent for because they're lost to follow up or you're unable to contact them or they've died. So in health data, we have what's known as a Section 251 approval, and that's approval from the Health Research Authority's Confidentiality Advisory Group. And that's to use patient identifiable information without consent for specific purposes. There's also ethics approval, so approval from a research ethics committee, and then organisation-specific approval, so gaining approval from those data controllers. And that might be just less formal, gaining approval from the Caldecott Guardian of an NHS trust, or it can be more formalised approvals like with NHS Digital's Data Access Request Service. There's also thinking about minimising the risk to patients. So only using patient identifiers for linkage purposes only, and then fully anonymising any linked data. Some data controllers may require additional steps there as well. So for example, within CRIS, we have our BRC ID, which is our patient level ID. And within HES, you have your HES ID. And actually what data NHS Digital require us to do is when we create these project specific linked data sets is we have to remove both of those IDs. And the researcher only ever sees a project specific anonym, and they can't link back to either original data source. There's also the use of trusted third-party safe havens. And these are organisations or departments within organisations who provide a service to keep that data, to host the data, provide the linkage service and to keep it secure. And the CDLS actually provides a trusted third-party service within SLAM. And that's how we can balance these. So I'm going to touch just very quickly on the process of data linkage. I'm not going to go into lots of detail about any of this, just a very brief introduction. But if anyone is interested and would like to know more, feel free to grab me afterwards. So the first thing to say is we don't link data. We don't create vast tables that contain all of HES and all of SLAM. What we do is we create a shared master patient index. And this is effectively a table that contains your ID from one system linked to your ID in the other system. And then from that, we're able to create these project by project data sets. And what that does as well, it enables us to apply data minimization. So we're not giving all of the HES data to a researcher. We're asking them to pull out the specific variables that they're interested in. And when we create that shared MPI, our aim is to link people between sources. And there are a couple of ways that we can do that, either by deterministic matching or probabilistic matching. So deterministic matching is when we match records on an exact match between various linkage variables. Whereas probabilistic matching works by assigning a match weight to represent the likelihood that the two records belong to the same person. But I'm not going to focus on probabilistic matching today. I'm just going to talk about deterministic matching. So we have here our GP record. We have our John Smith. He has his NHS number, full name, surname, sex, and date of birth. And we're going to match this GP record to our hospital data. And we can see here that both our hospital data and our GP data have this NHS number. So actually, we could just match on that, an exact match on NHS number. The problem is, as we know with clinical data and administrative data, that there can be errors, data entry errors, or it can be messy. We might have missing data. So actually, if we were to rely purely on the NHS number, we might potentially be missing lots of matches. So here we've got our second John Smith. Everything's exactly the same, except there's one number difference in the NHS number. So what we could do is use match ranks. So we could match on various different combinations of variables. And generally what you'll find is kind of your quality of your matching is going to decrease the lower down those match ranks you go. So we might say our first match rank is matching an exact match on NHS number, full name, surname, sex, and date of birth, whereas our second match rank might be on full name, surname, sex, and date of birth, ignoring the NHS number. And this can help in situations like this where we have a different full name. So it's clearly the same name, but it's the full name rather than the nickname. Also different spellings of names, particularly in kind of South East London, there's lots of different spellings of names. It can also account with surnames. So if people get married or divorced, change their surname. It can help with missing data. You can see here we've got a null sex. And then just another example of kind of errors in the data. So we've got our year in the date of birth is switched around. And it's about deciding where that line goes with your match rank. So we put that line too high and say we only want to match on the exact variables, then potentially we're going to be missing lots of people. We put that line too low and we're matching people who are not the same. So it's just about finding that kind of sensible place. And this is an example of some match ranks. So this is used by NHS Digital within their HES matching. So we can see we've got various combinations of identifiers that they use to match. And we see the score that they've given to the matches at each rank goes down. So the quality of the matching is believed to go down as we go further down the match ranks, but they do still believe it's the same person. So it's good enough to say that it is the same person still. So how can we test the matching? Well, in any data linkage, we're going to have our true match status, which is whether the person should have matched or should not have, and our linkage status, so whether they linked or they didn't link. And we can see that where these two match, then we have our true matches and our true non-matches. But where we have disagreement between these two is where we have our problems. So if our true match status is non-match, that person should not have matched, but we have linked them, we have our false matches. And where our true match status is match and we have not linked them, these are our missed matches. How do we know we've got it right? And in truth, it's really very difficult. And there generally isn't any independent gold standard that we can compare against. And most of the time, it's impossible for us to know what this true match status is. So I'm not going to go into lots and lots of detail about how to test matching, but if anyone is particularly interested, there is a group in UCL led by Professor Ruth Gilbert, who have done a lot of work into this, looking at linkage bias caused by errors in linkage. So I would definitely recommend having a look at some of the papers that they've done. But there is one option that is relatively simple and researchers are able to do it themselves because it doesn't involve looking at patient identifiers. And that's to compare your matched and your unmatched groups. So looking at those people who did match and comparing them to those who did not. And is there differences between them? Is there some potential bias that's been introduced through our matching? So another thing to be really aware of when using linked data is duplicates. And we know that duplicates exist in clinical data. But it's not for us as researchers to merge records. We can identify them and we can inform clinical systems teams that we think people are potential duplicates, but it's not up to us to make that decision to merge the records. But we do have to deal with them during data extraction. So I've got an example here. We have our John Smith in our GP data. We can see we have the same name, same date of birth, but in one we're missing the sex and we've got a slightly different NHS number. And we have our John Smith and our hospital data. So you can see that our John Smith 1 has matched to the hospital data on match rank 1. So he's matched on all variables are the same. But our second John Smith has also matched on match rank 5. So by including match rank 5, we have said that we think that the probability of those being the same person is good enough to include it as a match rank. But then how do we deal with this during our data extraction? So one option, and something that we do quite regularly in SLAM, is to duplicate the data. So we duplicate the hospital data so that we can accommodate both of those matches. Now that's just one option. There are options around consolidating data on the GP side, but I guess it depends on what's going to work best for your study. And generally we found this it's almost the safest way to accommodate both matches. And I just want to touch on a real life example. So this is a study that we work with. We do the data linkage for this study and we host the data. And the aim of the Elixir study is to link maternity and neonatal data for mothers and babies from 2 NHS trusts to mental health data from SLAM and GP data from Lambeth DataNet. And what that involves in reality is we have our 2 NHS trusts and we have mothers and babies that exist in each of those. And within each of those, we have the 2 systems, maternity and neonatal. So potentially we have mothers and babies who can exist in multiple systems. A mother can exist in up to 4 if she's had a baby in each trust and has had that child in neonatal unit in each one. So the first stage of this study is to link all of those together to create our master patient index where we have 1 row per unique mother and 1 row per unique baby. Once we've once we've got the kind of core data set, we then need to link that to the psychiatric data and to the GP data. And throughout this process, we can pick up on a number of different types of duplicates. I'm just going to focus on one kind of simple one that we see, and that's duplicate mothers in the same source maternity data system. So, for example, we have maternity data from King's College Hospital. What we will see regularly is a mother who has had 2 pregnancies, and for each pregnancy, they've been assigned a different hospital number, even though it's clearly the same person. And it, in some cases, will be this obvious with the same NHS number, same forename, same surname, same date of birth, but they've just been assigned 2 different hospital numbers rather than their new pregnancy being linked back to their old record. So as I said, we don't fix duplicates. So what we do when we come across this is we assign an Elixir ID to each of these people. So we do report them back. We will report them back to the source systems, and then it's up to them if they choose to merge the records. And what we might see is in a refresh of the data that actually that record has been merged. But in the meantime, we don't fix it, even though it's obvious. Now, what that means when we link that Elixir MPI to our psychiatric data is that we might get the same mother that links to just 1 person in our psychiatric data. And when that happens, what we do is we duplicate that psychiatric data, including all of the clinical data, so that we can match it to both of the duplicates. And it's important to be aware of how these duplicates are dealt with, because it can have some odd effects in the data. So with Elixir, what we might see in a very tiny number of cases is we have 1 baby who appears to have 2 different mothers. We also see 2 mothers who appear to have the same pregnancy. Now, it is a very small number of cases, but these odd things do appear. So it's really important just to be aware of them so that you can manage them in your analysis. So that's it from me as a very brief overview of some of the issues of data linkage. And before I hand over to Katrina, does anyone have any questions? Nope. Okay, I'm going to hand over to Katrina now. I'll let you introduce yourself. Do you need me to unplug anything? No. All okay. Cool.
Brilliant. Okay, so first I want to address the elephant in the room. These boots are absolutely amazing. They're the most expensive thing that I've ever, a piece of clothing that I've ever worn. The other thing is that the Chris team are fantastic. I've been overawed by the presentation today, even though I know most of this stuff. So I am not really part of the Chris team. I have used Chris for a number of purposes, and currently, so I started off as a clinician, but I've also been a kind of amateur epidemiologist for quite a long time. So when I moved into research, clinical data, working with clinical data was absolutely obvious. That's not certain data scientists like Matthew or Amelia, but I bring in another perspective on the data, having entered much of it myself. So my presentation is going to be about psychiatric diagnosis and medication, but my real aims are for you to understand the use of linked data for validation and be able to critically evaluate results from clinical data according to filters of care. If I do those two, I'll be very happy. But we could also get on to some of the visual ways of using linked data or explaining linked data. Now, I've put together a big notebook of ideas that I came up with for this workshop, some of which came out. There's also some things about data and data governance, which I've been preparing on behalf of the Green Party. So I've put that there as well. You might as well have it. It's lovely work. And so that's available at this tiny URL. And I'd like at least one person on the table to have access to this so that we can do an exercise later. So tinyurl.com/32VEH2D6. So part 1, diagnosis. There's a few introductions here before we get onto the data, but medical model of diagnosis is really based on pathology or etiology, and you can do a test and you can tell whether you've got that or not. Psychiatric diagnosis, by and large, lacks that etiological medical model. And that means that our diagnoses depend on syndromes, which are consensus of signs and symptoms. And there are 2 manuals that we especially use in psychiatry, ICD and DSM. Why use them? Because if we want to do research and if we want to talk to other people about disorders, we need to have a consensus on what we're talking about. So that's why we use them. Does it make them more subjective? I'm not ever, although I asked this question in my presentation, I'm not going to answer it, but I will answer connected questions. Okay, and now validation. And validation in this case is on diagnosis. So why is it important? Because we're going to use things like diagnosis to define cohorts or exposures or outcomes. And we want to know whether it's a sensible proxy for what we actually want to get at. And we usually prefer validated data sources over unvalidated. It's not necessarily that they're better, but at least we know how good they are. And some concepts in validation, which I'm sure you've heard of, but I thought I would include them anyway. Sensitivity is how well you can pick up those who are positive in the data. And positive predictive value, or PPV, is how good you are at picking only those people. And they more or less play on each other. So as your sensitivity goes up, often your PPV will go down. If your PPV is really high, so you're only picking out these really pure cases, then you're probably not picking out some of the others, so your sensitivity goes down. Now, the validation that I did was for UK Biobank. And this is a very large cohort study. It can be used by anyone. It's about 500,000 people who are aged over 40. They had loads of information on baseline, and they had consent to link to healthcare data. But the mental health researchers, and probably some people who are just, you know, what would you call them? Being contrary, wanted to know whether that linked data was good enough to use for research. So were the diagnoses on the data that we were linked good enough for research? And these are the linkages that we had. Anne's team did a validation of their GP records, and I, along with the other people on this report, did validation on the hospital episode statistics. Now, you've just heard about hospital episode statistics, but how does the government get hold of these lists of diagnoses? Well, what happens is when you're in hospital, the clinicians will enter things into your notes, which will then get summarised as a group of codes, and they will go to the commissioner, who is usually kind of the local authority, and they will send it up to the Department of Health. And when I wrote this, which was quite a few years ago now, so it's probably gone up, but it's 12 million records they had a year. And you could access them through NHS Digital. NHS Digital has just gone back in NHS England. We don't know what's going to happen to data, but hopefully it will still be available somewhere. And importantly, all the diagnoses, whether they're mental health, physical health, are expressed as ICD-10 codes. So this is an old diagram. This is not what CRIS looks like now, but just as a cartoon. What we did was we linked hospital admissions to the CRIS dataset. And here, okay. So the population was people who'd been admitted to SLAM, and we took that from their HES record. And we looked at diagnoses that had been made at various points. And we used this broad diagnostic group. So you can categorize medical disorders as granular as you like, or as broad as you like. And we were concentrating there. And so someone could be defined as having schizophrenia, a wider schizophrenia disorder, bipolar disorder, or unipolar depression. And they could have them at various different points. So from CRIS, we had what the clinician wrote in full text. And then we had what was actually in the structured data. And then we had the HES diagnosis, because all of these people were chosen because they had a HES diagnosis. And then we looked at all of their HES diagnoses they'd had over time. And we chose the most common. And going from full text to structured text, 24% of the diagnoses differed. So they moved between those categories or other. 21% of the time, the CRIS record and hospital episode statistic disagreed. And 28% of the time, over time, the HES diagnosis changed with multiple admissions. But all of that is a bit kind of moot, because what you want to know is how does it compare to the actual diagnosis? Well, unfortunately, we're never going to get at the actual diagnosis, but what we can do is we can try and come up with a kind of gold standard research diagnosis. So I did a deep dive into the CRIS records of these people. And I completed what's called an objective psychiatric diagnosis using a structured tool. So that at least it's kind of reproducible. They had this symptom, this symptom, this symptom. Algorithmically, that gives you that. I did 250 records. Someone else did 100 that I had done as well. So we have some inter-rater reliability. Now, the really striking thing about this is 51% of the time, we, the researchers doing research diagnosis, said actually it doesn't exactly fit into any of those categories. But we were quite good at making a best guess, because 81% of the time we agreed with the diagnosis that it wasn't exactly. And if we took the end diagnosis as being what multiple HES episodes would tell you, comparing that to the research diagnosis, for schizophrenia was quite remarkable at 83%. Now that's as high as you get for strokes and heart attacks. Bipolar depression were a little bit less, but I want to really drill into this schizophrenia statistic. So was the PPV a schizophrenia diagnosis 83%? Well, strictly speaking, yes. the 78 we picked out, 63 had a research diagnosis. There's 3 caveats. The first, PPVs are really setting specific. And the thing that they really fluctuate with is prevalence. So the more common something is in a cohort, the higher the PPV will be. And this was quite a remarkable cohort that had been specifically gathered, and it had a prevalence of schizophrenia of 35%. But most of the places where you'll be implementing, looking at the HES diagnoses, probably you would have a prevalence of about 1% for schizophrenia. Second caveat is about the granularity. As I say, we chose to do broad diagnostic group. If instead we look at how accurate it was for the exact diagnosis, like paranoid schizophrenia, hebephrenic schizophrenia, that was only right 44%. But if we go out here to the wider, we can actually improve the performance. And in fact, we can say that 100% of the people who had schizophrenia on their HES did have some kind of mental disorder. Out of the 250, there was one who was kind of on the verge of like, were they playing the system or was there something wrong with them? But if it says schizophrenia, bang, they all had some kind of mental disorder. So depending on how tight you need to be with the diagnosis you're looking at, you can get really quite high reliability. The third one, it might not sound like much, is about secondary diagnoses. In the HES record, 6% of the cases, so 15 cases, had a secondary diagnosis. But in the researcher diagnosis, we had secondary diagnoses in 45% of cases. And often researchers will want to concentrate on schizophrenia that didn't also have some of these things. And using the HES record, they wouldn't have known that they did. So it's harder to get your pure cohort again. So there's a second aspect. We've looked at the PPV, so the precision, now looking at the sensitivity. So HES is quite insensitive to mental disorder. So if I told you in Lambeth, 8% of all people with a HES record, so who've been to hospital, have a mention of a psychiatric diagnosis, where we know that the prevalence of mental health problems is far higher than that. Even those who were known to mental health services, only 34% of those with a HES record had a psychiatric diagnosis, and only 2% of that was from a psychiatric admission. And why so low? And this is where we come to this model called Filters of Care that I really like by Goldberg and Huxley. And they say, well, it's really low because basically it's the top of the pyramid or the tip of the iceberg, because lots of people experience symptoms, but not everyone can get through the illness behavior. So recognizing there was something wrong, going to seek help, and the doctor that they sought help from also recognizes that there's something wrong and makes a diagnosis. And usually they'll be able to treat in primary care, but it may be that your case is complicated or severe and you end up in secondary care. And it's only those who cannot be treated in the community that ever make it to an admission. This is the same pyramid again. It looks different. So Goldberg and Huxley came up with this model to explain the prevalence difference. So the fact that you've got lots of people experiencing mental health problems, but if you looked in a specialist service, you'd only find a few people. But I had a slightly different question, which was, are the people in these different bits of the pyramid the same? So in the original model, each level is a subset of the one before. And the thing that gets you up towards the tip is how severe your problem is. So we repeated this pyramid, but using lifetime depression prevalence. And these are all from UK Biobank. And so now you see lifetime symptoms of depression, seeing GP for mental health, diagnosis of depression, taking antidepressant, admission for depression. And those are the prevalences that we found. But we saw, instead of each being nested, that actually these were actually different populations that overlapped to a more or greater degree. And I wanted to know, as you ascend this pyramid, are you more likely to have a severe episode of depression? Well, yes, you are, but you can see there's some kind of waste here. W-A-I-S-T, that goes in. And it seems as though you were slightly more likely to have a severe depression if you had symptoms than if you had gone to the GP for symptoms. Now, this might be showing something called the inverse care law, which means that the people who most need care find it the harder to access. If you look at recurrence rates, so this is percentage that have more than one episode, and you can see that's even more wasted, W-A-I-S-T, so that the people who saw GP for mental health and the people who had diagnosis of depression were more likely to just have one episode, whereas for the others, they're more likely to have recurrent depression. So it's like people go to the GP and get diagnosed when they had this discrete episode that's out of character for the rest of their life. And then here are 3 factors that seem to concentrate in the admitted proportion. So self-harm and suicide attempts, 27% in admitted. Psychotic experiences, 18% in admitted. Manic symptoms, 10% in admitted. But I think you could have guessed that. Why could you have guessed that? Well, I would say out of all of the people who have depression, these are the people you admit. They're the people who have suicide attempts. They're the people who have gone psychotic. They're the people who you think might have bipolar. And again, here are 3 other things that we looked at that probably differ a little bit less. So PTSD symptoms seem to go along with the severity. Hazardous harmful alcohol use. This is just endemic in UK Biobank, probably the world, but you can see it there. Physical comorbidity, now I can't explain this, maybe someone else can, but it's really concentrated in the taking antidepressant and the admitted group. I don't know if anyone wants to proffer a theory. No, I don't know either, but it's true. So, summary. Psychiatric diagnosis is not yet a precise science. Categorical diagnosis using ICD or DSM is widely used, and validating clinical data against research standards can help show the strengths and limitations. So what are the strengths of clinical data? It can have high PPVs, especially in settings of high prevalence. And it's especially good for finding people with a broad mental health disorder diagnosis. The weaknesses, sensitivity is always going to be poor because we just know that a lot of people go facing every day with mental disorder that hasn't been diagnosed. The recording is going to reflect both the clinical picture and external influences. So if your local hospital has a problem admitting people, they have no beds, maybe the waiting list for your CAMS is 3 years long, you're not going to refer up, you're not going to see those admissions. So clinical picture, but also external influences. And these highly granular routine diagnoses that you get, they're not stable over time. And sometimes that's going to be just over time, you meet different criteria. So for example, for a diagnosis of schizophrenia, you might have to have symptoms for 3 months, or you might have to have symptoms for a year. And until you meet that, you're not going to have a diagnosis of schizophrenia, even though 2 years later, if you looked back, you can see this was an episode of schizophrenia. Make sense? Medication. So this is my PhD. What I'm looking at is some things that are frequently prescribed to people as they age, but I'm looking at them in people with dementia. And I'm seeing whether taking these has good or bad effects on people with dementia. And as we've heard, there's lots of clinical data out there, but it's all in different silos. And I wanted to use Chris to do this, but I've written the anonymous mental health plus EHR. But how did I know whether the prescribing of these physical health medications was good enough to use for research? When most of the time for someone with dementia will be in primary care, it won't be in the secondary care. But what I could do was, for one of the 4 boroughs that Chris refers to in Lambeth, they have also a research database. So we linked with those. It wasn't me, it was Matthew did a lot of it. One of my colleagues called Sarah Dorrington, Mark Ashworth. Thankfully, I didn't have to do the linkage, but I could use the results. So the Lambeth Datanet has coded data, no text data, but it does have coded prescriptions because the GPs are the ones who are doing most of the prescribing. So what I wanted to know was Chris prescribing, sorry, that doesn't make sense. The prescribing that we found in Chris, which has come via the NLP app, how did that perform against the prescribing that we could see in Lambeth Datanet that the GPs had done? And here's a list of the medication that we used. Just take a minute, read the list, and tell me which one do you think did really good, i.e. in Chris, it was able to pull that up most of the time, and which ones did really bad, i.e. they weren't really so much in the mental health record. Well, the trust included memory clinics, who were the people that recommend or start people on dementia drugs. So I thought they might do quite well as well. And here is how well they did. So the height of the bar shows you how often it was prescribed in the primary care database. And the blue bar shows you how often that was matched with an NLP hit in the Chris record. So you can see for dementia drugs, 96%, antidepressants, 91%. So you can really trust that if it's in the Chris, you're going to be picking up most of it than the wrong way around. Shall I start that sentence again? I think I might. If it's being prescribed in primary care, you're probably picking it up in Chris. The 2 drugs that I'm most interested in are statins and aspirin. You've got 85%, 75%. I'm pretty okay with that. But what about calcium with vitamin D? This is only found a third of the time. So the GP was prescribing it, but using the NLP app, we were just not picking it up in Chris. I think I've not given the proper name there. To pick it up in Chris, a clinician would have had to have written calcium with calciferol. Any contraction, any CA with calciferol, any calcium with vitamin D doesn't get picked up by the NLP app. And that's why I think that's so low. I showed these figures at a clinical academic group for old age psychiatrists, and I went in with this kind of okay-ish model of why some things weren't recorded very well. And I came out after a really productive discussion with a nice model of the facilitators and barriers. So yeah, this is one of the lessons learned is just discuss it with loads of people, and especially the people who are making the data, so the clinicians who are recording. Okay, let me just, right, intermission. Any questions? So I need another peppermint tea. If you want to refresh your glass, have a glass of water, have coffee, come back in about 5 minutes. 3 possible tasks, but what I'm going to recommend is that we do a practical linking task, which is about prescribing. Back to UK Biobank data. We wanted to know if you could tell what mental health problems people had by what medication they were taking. And you can see that for antidepressants, sensitivity is quite low, but if they were taking it, good likelihood they had depression. Lithium was a bit, but then lithium was hardly taken by anyone. Antipsychotics. Of the people who were taking antipsychotics, only 49% of them, less than half of them, did we think, and this was using their hospital records, everything they said, only half of them we thought had a psychotic illness. Or show that as a chart. We thought these had likely psychotic disorder. A few more people who were symptomatic but didn't have a diagnosis. And all of these, including people who didn't seem to have a lifetime history of depression or anxiety. And I presented this at an international conference. It must have been 2018 or 2019. It was before the pandemic. And someone came up to me and they said in this kind of stage whisper, "It's quetiapine." Quetiapine being one of the antipsychotics. And a couple of years later, they published on the data that they were telling me about. And their graphs aren't super clear, but I'm going to try and explain them. So all of the graphs have a top part and a bottom part. The top part is to do with the prevalence. So they've had a prescription and at least once in the year, and it goes from 2006 to 2016. So you can see here, the number of people who had a prescription was staying steady. And the bottom half is something called a defined daily dose. And you can see it's out of 1, goes from 0 to 1. And the defined daily dose is a really good trick. If you're going to be looking at medication, you want to know this trick. So I'm going to tell it you. It's about looking at whether people are taking something consistently and at the dose that would mean they were getting benefit. So if you were taking paracetamol for pain and you were taking 4 grams a day for 100 days, you could see that you'd taken 400 grams in total over 100 days, and you would know that you were taking that 4 times a day for pain relief, because that's what it would entail. When this starts to fall is where you're taking paracetamol just once or twice a week, and you end up just taking, say, 100 grams over 100 days. And that's what this is showing you. So this as a proportion, so out of 1, how many total doses were being taken by the population. And you can see here, it's about 0.8, and it's steady across time. So most people are taking at or about the needed dose to get a benefit. So that's defined daily doses per user per day. And so at the top, the one that I was just showing you was olanzapine. So this is a second generation antipsychotic, very widely used. And you can see that over the time, this was staying more or less steady. These are different age groups. These are the adults, and they're taking at least, these are 3 countries, but the top one, they're taking a whole defined daily dose every day. The other chart looks completely different. This is quetiapine. Over time, more and more people are taking quetiapine, but the defined daily doses is down here. It's about half. And it's actually going down over time for the adults. And this, although I can't prove it, seems to imply that people are using quetiapine for something like sedation or sleep. It's given to people to take as and when, just to get them through the days. That's my theory anyway. What I would like you to do is design a study that replicates that using data from people with a Lambeth GP. So this is where you might need your notebook if you still have it. So is there someone with the notebook open on each table? Have you got a notebook open? Okay, so there are 3 tasks. We go 1, 2, 3, 1, 3. And if you go in the notebook, there's 1, 2, and 3. So the first team is going to find a way of finding out whether people are taking antipsychotics. The second team is going to try and work out how we can get a defined daily dose per user per day, or per user. The third group are going to see if we can stratify by those who have got a psychotic illness according to the mental health record. So there's a diagram here of how all the different tables interact. You can see that most of them link through a pseudo NHS number. And that's like a single identifier that Amelia helped bring out. But some of them have 1 record per person. Some of them are recorded every time a diagnosis or every time someone registers with a GP. And so the task is to be able to get these tables into a state where you can link them with each other, and that will answer the question. So for the group that are looking at how we can say whether someone's had an antipsychotic, well, how can we get this prescribing table into a state where we can then link it with the patient list? For people who are looking at defined daily doses, you have to find some way of using the database to work out how much of a defined daily dose was being prescribed here. So if you look in the notebook, it will break it down question by question, and I'll come around and have a chat. This exercise is more about getting you to think about different data tables, and we talk about this formal data linkage, but when we're actually doing these things, we go far beyond that to lists of medication, the DDD lists, and we have to make decisions all the way through it. So those groups who were looking at antipsychotics and trying to find out who was taking things, you need a list of antipsychotics, and you can get that any way you want. And then how do you identify a prescription as having an antipsychotic? And as I said to some of you, what you find is the primary care data has it as text. And that's quite difficult to deal with. So then you need to find either you're trying to get out the medication name, but then here, this medication name called Abilify probably won't be in any of your lists of antipsychotic medication because its actual chemical name is the aripiprazole. It's actually a brand name for aripiprazole. But because aripiprazole is fairly new, you will find brand names when you start going back in time. So the way that I have taken to doing it is to then use a lookup, which has these codes, and these are SNOMED codes. I hate SNOMED. Okay, I could go on for a long time, but if you look at these codes, they completely screw up as soon as you put them in Excel. Latillo. And they don't have any characters in, so Excel can't tell that this isn't just an extremely long number. So yeah, it's a problem. But having the DMD is also useful because it means that you can add on to the prescribing records by linking on the DMD number, and you can get the medication name. And crucially, it will have the generic name. So these codes that were for Abilify are in the DMD table, but they say they're for aripiprazole. So that's just a really useful way I found of doing these things. And I put in, these are R, but that's just a vocabulary. So things that you're going to need to be able to do is just identify multiple rows that have the same ID and somehow collapse those down. Or we can talk about another way of doing it in a minute. So there was only one group who was doing CAS2, but they were quite a big table. So I thought they're probably up to the task. But one of them, I said, you can get the DDDs from the WHO website. It was up in a second. So I know I chose the right table for that. But again, you've got the medications here, DDDs here, and just adding those onto each prescription record will mean that you then be able to calculate those extra columns. So then you're going to have this prescription table with lots of lines per person, possibly going back 10 years because we're doing 10 years of data. Maybe they've had a prescription every week because they were particularly vulnerable. You've got a really, really long prescription table. And so learning how to do long to wide manipulation of the table is going to open up real possibilities for you. And when you do it, I don't use spread, but I use something called dcast. Similar. You can tell it which columns you want and how you want to combine them. So when you've added your DDDs at the end and you've seen how much is being prescribed, you can then summarize that when you do your long to wide and keep all of that information, but get the table into a form where it can link to the patient data. So team 3, we're trying to work out or have a flag for who had a psychotic illness. So this one, no. How nice schizophrenia? Yeah, we probably say that. But of course, you're not going to do it like that. You're going to find a list somewhere that you've thought about. Some people just using F2s, some people are adding in some affective psychosis. we're modelling a different study, so just have a look what they did and work that in. But you're then left with the fact that some people have lots of diagnoses, as Amelia and everyone said. So you're going to have to change this long form into a wide form. And this table is only for people who were in the mental health system, because that's where we're getting the diagnosis from. When you link your table back to your cohort, down here somewhere, the ones in orange, where in orange? These don't have a CRIS record. So when you link this diagnostic data back to your patient list, your cohort, what will happen to the ones that have no match in the mental health system? Yeah, so there are two. If you do, and again, it's a bit technical, but most of the time you do what's called a left join. So you take your cohort, there's your cohort, and you match the new data onto that, keeping all of the ones who are in the cohort. So for the ones who don't have any mental health data, it would just say NA, NA, NA. And be aware of that, because you are linking onto that something which had a 1 if someone had psychosis and a 0 if they didn't have psychosis. And you're now adding in NAs to that. So you have to deal with that at some point. Okay, I wonder if I can get the slides back. So I don't have much longer, but the tool that I used to make the diagram, I'm quite in love with at the moment. It's called Draw SQL. If you do any work in SQL, you can actually import it in and it will draw the diagram for you. Quite cool. That's that one. But I'm going to go here. Cool. So this is a slide that I use quite a lot. This is something called an Inukshuk. My mum's a poet and she writes poetry about Inukshuks. They're quite cool. But what occurred to me about these is it's kind of an analogy to clinical data. Everyone who goes through mental health struggles is leaving these pebbles on the way for us if we know how to find them. And we can tap into their experiences by using their data. Linking databases gives more complex and complete data. And patients are generally surprised that we're not already doing it in research. But it needs to be done in a responsible way, both in terms of privacy and also statistical rigor. You don't want to be finding rubbish with their data. So, more closing thoughts. Clinical data has many surprises, and way to help you manage your surprises, things like external validation of what the main variables you're doing, considering the filters of care or the patient journey so that you can see what biases your data might have. Speak to people who are making the data and speak to people using similar data, like the guy who came up to me in the conference. Data linkage is hard. Try and embrace making the methods of your data linkage really accessible so that you understand, so a team and network can help you, and so that you can engage patients and public.
That don't know me, I'm Angel. So I'm one of the co-directors with Rob Stewart of DataMind, and we've got a session in a bit to talk to you about that and hear about extra things that you want from us in these workshops. But it is my great pleasure to introduce Louise and Elena, who Professor Arsenault, Louise, leads our so findable, accessible, interoperable and reusable data workstream in DataMind. And she also leads the catalogue of mental health measures, which for people like me, who are older than most of you looking at you, we used to have to do this stuff ourselves. So if we had a research question and we wanted to find the data where we could answer it, it was mind-blowingly painful. You had to go through these like PDF books that often you had to get in hard copy because they weren't available online. So you may not fully appreciate how transformative things like the catalogue are for researchers. And in DataMind, we're further increasing the utility, but also doing other sorts of work about things like, you know, how many people with schizophrenia are in birth cohorts, you know, so there's not many, but you might be able to group them all together. So I'm going to hand over now to this amazing duo.
Thank you very much, Anne. And can I check that the microphone works well? Are you happy? Perfect, great. Thank you very much for this introduction. And so I am Louise Arsenault, and I work as part of DataMind, and we are in charge of the FAIR mental health data. And today it's great because we had the opportunity to tell you a bit about the catalog of mental health measure, which is something that we've been working on for quite a few years now. I will simply kind of, and hopefully very quickly, give you some background about the catalog, but the most interesting bit will be with Elena, who will do with you some kind of a demo so that you can use it. No, this one. Yes. So the project really aims to create a hub with information that was already collected. So we're not inventing anything new here. It's really getting all the information about mental health data collected in longitudinal and cohort studies in one place to make it easier for people who want to do secondary data analysis or who wants to kind of start a new project based on already collected data. They can find all this information into one place. And we did that also to encourage the use of existing mental health measures. So longitudinal cohort studies are a very big investment for funders. And quite often we realize that the investment is not matched by publication and use of data. So we wanted to encourage people in using those mental health data, and especially encouraging people from different disciplines. So not just mental health researchers, but encouraging people from different backgrounds in integrating mental health in their research projects. We also thought that that tool would be especially interesting for early career researchers who have to handle and juggle multiple priorities. And we thought that actually, if you need to kind of write your first grant and publish at the same time, maybe you can use already collected data for your publications while you're writing your grant to collect your own data. So we thought that that might be especially interesting for you guys. And another aim was to promote work on data harmonization, but also harmonization is something very challenging, but there's also scope for creating work across different cohorts. So if you want to replicate your findings using different cohorts, so the catalog offered that possibility. Just checking, yes. So the catalog is not just about mental health conditions, but it's also about the positive aspect of mental health. So we are also looking at well-being. So we couldn't find any proper word. It's not problem, it's not difficulties, it's not disorders. So we call it topics, basically. So it covers quite a wide range of mental health and well-being topics, including, of course, mental health conditions or disorders, but also well-being. Also measures of impairment, help-seeking behaviors, diagnosis by a a professional or GP. So we kind of capture all this information, very detailed. Helena will show you, and we don't capture only standardized scale. Even if there's an item which is randomly included somewhere in these massive questionnaires that Anne kind of told you about, we would kind of spot it and we would kind of record it in the catalog. I think there's a slide missing, but that's all right. Just to give you a slight background about the development of the catalog. So it started in 2017 when I was appointed as the Mental Health Leadership Fellow for the Economic and Social Research Council. And I organized some kind of focus group in saying to people, what shall we do to maximize the use of those already collected data on mental health? And as a group, we kind of decided that it could be useful to put all this information in one place to support mental health research. We got funding from CLOSA the following year, and it was for only 1 year. So we had to be very focused in what we wanted to do. And in 2019, we did kind of launch the catalog, and we were a small team at that point of 4 people. And I think that we all kind of remain in the team now. At the end is the web developer. Very identifiable. He's the one who created the catalog that you're gonna see. But we did identify close to 50 cohort in 2019, and close to the launch, we had reviewed 30 of those cohorts for their mental health and their well-being measures. As time kind of goes by in 20 and 21, of course, we didn't plan we didn't plan COVID in our projects, but then we did kind of consider COVID in the catalog. So yeah, there is a section about longitudinal cohort already established prior to the pandemic and how they consider the effect of the pandemic on mental health. We have that in the catalog. We also added filters on social care. And just recently, you may have seen on Twitter that people at the London School of Economics have launched the catalog of social care measures. So that is a spin-off from the catalog of mental health measures. And then we kind of kept on adding new studies to the catalog. So we kept on building and building. Oh, and we added members in the team as well. A little bit later, we can see that we reached our 50 studies in the catalog. We added information about physical health measures, and we also added measures of personality and temperament. And most importantly, we included Elena in the team. We recruited Elena in the team, which was great. And also, most importantly, we joined Datamine, this beautiful group of people who work on mental health data. So that was very exciting for us. And we've been working with HDR UK, of course, and their platform, the gateway in making data more discoverable. And we're trying to kind of find intersections between the different platforms. So their gateway and the catalog of mental health measures. And then as we go still further, you can see that we've been expanding the catalog with adding new measures because, of course, the longitudinal data studies, they keep on collecting data. So we need to have the catalog updated on a constant basis to make sure that it does reflect really all the data available from those longitudinal studies. So we keep on maintaining it, and when we have funds, then we can expand it. So that's good news. And recently we've added even more studies. So now we have 55 studies, and we've recruited Maleka and Danielle as part of the team as well. So that's really good news. And recently we've been neglecting the catalog for the past 6 months or 8 months because we've been focusing on the similar project funded by Wellcome. But now very recently, we kind of went back to it and making sure that we can expand further. So I told you that the studies included 55 studies. And just to tell you, we were very strict into how we define longitudinal studies. but basically they had to have at least 200 participants at inception to make sure that through the years they would have enough participants to run analyses. Of course, they would have to have mental health measures, even if it was only a few. We thought that sometimes a study which is focusing on a different context, but have a few mental health measures, that could be really interesting as well. So even if there are only a few measures, it is included in the catalog. It also has to be UK based. And again, because we started only with 1 year funding, we had to be very focused. We also include some international consortium, but they need to have an important component in the UK. So I think that these are all the logos of the different studies included in the catalog. This is my last slide. It is to say a big thank you to all the longitudinal studies, because we couldn't be doing this ourselves without the support of those studies. And while there were some people who were very skeptical at first when we started the catalog that the studies would not work with us, actually none of them said no. They were all very happy to contribute to the catalog. And I think that they did that for a few reasons. First of all, they are conscious that they need to make their data available or more visible. So they were very happy for us to use their data, and they were proud in some ways. When we contacted them, they felt privileged. So that's good. And now I think that people are contacting us, saying to us, we want to be part of the catalog. So that's absolutely wonderful. But also, they were happy to contribute to the catalog because we were doing the job. So we didn't ask them to do the review. We would say to them, give us all the material that Anne mentioned, all those kind of PDF, and we would do the review ourselves. And then we would share with them our review and say, can you please check everything is complete and accurate? But we did all the job. So that was great. We didn't want them to do it. We rather kind of do it ourselves, but they were happy for the contribution. So that's a bit of a historical background for the catalog, but you could see how it developed and what it offers as well, on top of a very detailed description of the mental health measures. And now I will leave it, Elena, take you through the catalog and show you how we can use it.
Louise, I will just bring up this slide. If you could, if you would want to join me in this tour of the catalog, you can feel free to look it up, but I will talk you through everything, and maybe after the session, feel free to explore the website. So here is the main page of the catalog, just like any other regular main page, but here we also highlight our collaboration with Datamind. And just to quickly mention that here we have a section to subscribe to our mailing list if you would like to receive updates from us about the new studies and new sweeps that we are including on the catalog. So here there is some background information about how we gather the information and who is working on the catalog. Then a step-by-step guide about how to use it, which I'll talk you through right now. And then finally, here are some explore pages that can be very useful when either considering a research question or looking for some resources or other training opportunities online. I'm not going to go through all the pages here, but I will just highlight this mental health topics page, which is meant to provide the definitions that we use when we look through the documentation that Louise was talking about, and get to define some of the common mental health topics that we find in the cohort studies included in the catalog. So these definitions are primarily based on the DSM-5 and the ICD-10, but I would just like to really highlight the topics that are not defined by those documents. So for example, psychological well-being does not have a strict definition. So this is where we explain what we mean by it when we review it and include it on the catalog. And then perhaps this would be of interest for the group, especially considering clinical data, we also define what we mean by treatment and service use. So I will show you this when I go into a specific study later on, but it's basically an informant reported item that they have received treatment or service use for a mental health condition. So now for the main course meal of the catalog. Here is the search page, and here is where you can find the list of all the longitudinal and cohort studies that we have included on the catalog. You can either scroll through here, or if there is a study that you know about, you can just look it up and further explore. There are information icons throughout the catalog that are meant to facilitate your search. So hovering over them can kind of explain either how to use the search tabs, or they sometimes further define the measures that are included in each cohort. Here, I would also like to highlight the filters section. So here is where we summarize or provide users the option to filter their search. So perhaps there's not a specific study that you know that you want to search for, but instead you know that you are interested in particular measures or variables such as education. And by filtering through, you can narrow down this list on the right. So we have this list of related measures and then some complementary data that has been collected for the cohort studies included in the catalog, such as linked data, which is again of interest to the group. Then study design, sample characteristics, age at recruitment, sample size, geographic coverage, and start date of the cohort. So we have cohorts all the way from 1930s. So maybe I was thinking that maybe it would be useful to demonstrate how somebody with a clearly defined or semi-defined research question could go in and use the catalog to facilitate a project. So let's assume that I am interested in factors associated with anxiety in older populations in England. First, I would go in and search for the term anxiety. And I'm also interested in their use of services in England. So I could search for the term anxiety and then either search for the term treatment and service use and refine my search like this, or keep it broad to anxiety and then filter here through administrative data. And the catalog might recommend that my search might be more broad to also include emotional problems, psychological distress. But if that's not what I want, then I can just undo and keep it just to anxiety. Then I know that I want an older population, so I can filter through an aging cohort sample, and then I want the sample to be based in England. I want it to be a relatively recently recruited sample, so I will narrow it down to here. And after exploring the catalog, I realized that I'm also really interested in cognitive decline associated with anxiety. So this might be the top search item that comes up for me when I implement all of these search options. So after going in here, this is where we, for each cohort that we have included on the catalog, we summarize the main aims of the study, where it is based, the geographic coverage of the sample, as well as some additional sample details like recruitment, sample size at recruitment, and sample size at most recent sweep. Further down, we also include information about the data, so and information about how to access the data itself, then other types of data collected, and what type of linkage data might be available for the study. as well as the cohort profile paper, which is where the cohort is described. And then one of our most recent features is the impactful papers that have been published using the study data. So this could provide further inspiration or just more information about each study and how impactful it has been in research. So scrolling further down, this is where all the PDF information becomes compiled. And while we do not provide direct data that has been collected from participants, we provide the type of questions that they have been asked. So if somebody was interested in this study, for example, and to use data from the study, they could request the variables they are interested in following the data access link, and knowing what they want to ask for based on this timeline. So we can see here the types of measures that have been collected at each wave of data collection. Again, this is the information icon that I was talking about before, and this is which provides more information about the measure. Here we can sort by whether an instrument is a standard measure or not, and also look at the types of questions that each measure asks about. So going back to the research question that I'm interested in, that is about anxiety. Here I can see that it has been collected at every wave of data collection. And it has been asked as whether somebody has received a mental health diagnosis of it. And to see the exact questions that have been asked of the participants, we can expand this plus icon and look at it here. So here is where we can see the questions and the response scales, and if there were any notes associated with this item, they would be summarized here as well. So even though this is not a standard instrument, we know exactly what the participants have been asked. So this can help shape the type of questions that we might want to ask as researchers. So looking through, we can see that in every wave, this item has been asked of participants. But let's assume that we've reached this wave here and we see that the cohort has also been asked about anxiety using a standard measure. And all of a sudden, we realize that we would want to include standard measures in our research project. So we could go back to the search page of the catalog and search by standard measure name and apply the same filters in an aging cohort. And let's assume that we don't mind that the participants are not based in England anymore. And this could then become useful if we are ever interested in maybe a cross-cohort comparison or any sort of harmonization analysis in our research. So I think this brings us towards the end of the tour of the catalog and how it can be used to facilitate research. It has summary and overview information and is really meant to serve as a starting point when asking research questions. I hope you can tell that both Louise and I are very passionate about the catalog. I hope you have also developed an appreciation for it, and thank you very much for your attention. If you have any questions, please let us know. Yes, if you could go back to the slides. But if you don't have questions, then we can also do an activity of searching through the catalog to kind of get a sense of what it is like to use it. But if you do have questions, then we would be happy to answer them. Okay, so the catalog can be used as a tool to identify a study, and then we provide the resources about how to access the data. We provide the types of questions that participants have been asked. We don't provide the data itself, but instead can signpost onto where a researcher could look in order to retrieve the data. So I don't know if that answers the question.
Yeah, that's on the same site.
Right.
So yeah, I think that the cities became, are still the owners of their data
Mhm.
because they know their data best somehow, and we are just at the middleman basically. But we indicate to people where via a web link who they can contact to access the data, and you have lots of variation. Sometimes you can just download the data very quickly, so that's fine. Sometimes you have services like UK Data Service that kind of handles the big cohorts, and again, you can just access that website and you download the data. Other studies will kind of want you to fill some kind of a concept paper form where you have to kind of list what is the project, which data you want. That can be reviewed by a committee, and then you will have access to the data. But in some ways, I think that data access is something which is still specific to each study. And we encourage people to really knock at the door and ask for data when you have a good question.
Did you have a question?
I'm sorry if you did share this, but can you render it so you can directly compare measures from different studies at the same time?
Not yet. So stay tuned, maybe. I don't know how much.
Yeah, I think that we're working with the web developer at the moment to kind of make that kind of comparison.
Yeah.
So yes, so that should be, or yes, I'm not even sure whether we can do it at the moment using the API, but I think that we just need to have a tutoring session with him to show that. But that's definitely in the pipeline.
Yes.
That should be soon.
Because that would be very useful for sure. Yes.
Yeah, so I think that you need to be careful about this. But if you look an example with the NCDS, for example, kind of lifelong between birth and age 60, they use the malaise inventory for psychological distress. And they start with something like 36 items, I think. And through the years, because of time pressure, they reduce it. And I think towards the end, you only have 9 items. Yeah, okay. So you can check, but we list all the items so you can see which ones remain through the years.
And for questions, oh, sorry. Go ahead.
No, that's a good
Yes.
that's a good question, because that is an issue for lots of different studies that do not necessarily kind of keep the same questions through the years. So it's important that you can spot that.
Time to go through all the questionnaires.
Mm-hmm.
Oh,
every
absolutely.
year. So it's good when we come together.
Yeah.
Yeah, so what I would say too is that even for the measures that are non-standard, if the reason why we categorize them in topics and scales is so that at least you can get a sense that the same variable has been asked about, but maybe in different ways. But I think that's up to the user and the researcher to identify. But yes, at least sometimes it has been asked over time, just in different ways. I think though, we can't have an effect on how it has been asked. Yeah, or we don't highlight if it has been asked differently, only if there have been, a fewer number of items of a standard measure asked over time. Yeah.
And I just want to say that we are very open. I think that we kind of thought about this project and kind of we have a proof of concept somehow that has been developed through the years. But for us, it's very important to hear from the users. What would be important? What would be useful for you when you conduct your research? What is missing on the catalog that you would want to see to facilitate your research? So we would like to hear from you. So I know that for us, the next step would probably, or possibly, we've been aiming to kind of do that for quite a few years, but we would want to add some international cohorts from different countries who may do kind of things differently. But there are some studies, that have proven to be very important for mental health research. They're just not based in the UK. So I think that for us, that would be an important step. But we are very much happy to consider the users' request. What would be helpful for you guys? So do get in touch. And we're also working on a different project, which is similar to that, where we had to landscape all the longitudinal data set in the world. So that's a nice complement to that. And as you can imagine, we will not do the same thing on those 3,000 longitudinal data set that we identified, but we will develop a platform that people can also search for mental health data. So that's coming in a few years.
We have these two slides are kind of what the catalog does and does not do. There may be a practical, oh no, there is not. But yes, please do get in touch if you have any other questions that come up, if you want to explore the catalog and have any suggestions, get in touch for that as well. And that's all from us, I think.
Thank you.
Yeah, thank you.
So Rob and I are up and we've been given roaming mics, which I think is probably a bit frightening for everyone. So I think the purpose of this session was partly to find out from all of you what we should be doing as we go forward. So basically, as part of DataMind had 4 arms, has 4 arms. We've heard about the catalogue. There's one that's on patient and public involvement and engagement that is really active. And one of the big things there, so we heard a bit about, consent, opt-in, opt-out earlier this afternoon. And one of the things that people feel uncomfortable with in general, they're quite comfortable with researchers and the NHS accessing their data for public benefit, for public and patient benefit. They're less comfortable with industry. And so one of the things we're doing is we have an industry forum led by Andrew McIntosh up in University of Edinburgh. And we have our patient and public group. And we've developed a data literacy course because often we think we're all talking the same language and we're not. So we had one meeting where the word profit was discussed between the public and industry for about 25 minutes, simply because what people mean by profit is different. So it's really hard to have conversations about who uses what data for what, if even, what seem like relatively simple words don't mean the same thing to everyone. So that work is ongoing in terms of developing guidelines. And then the 4th arm is about sustainability. Sustainability is something that research councils for big so DataMind is essentially a network, and it's a very open network. It started with 11 universities across the UK. We've taken a properly 4-nation approach, and I'm doing this bit if Rob is puzzled, because Hala said that people want to hear a bit about DataMind because it wasn't on the agenda. Sustainability is a really challenging one when, so I come from a clinical background in primary care and public health. And now I'm a researcher, and now we're meant to be developing a project that is sustainable. And projects are sustainable as, we're all used to generating grant income to sustain the work that we're doing. But in order to sustain the sort of data work that we're doing, there are services and things that we offer in terms of accessing data, holding data, making it more findable. So what Louise and Lena have just talked about is that thing of making data discoverable and reusable. So for many studies, so people like me, I now sit on grant application boards. So I sit on the longitudinal population study panel in the MRC. which means I know now what all those longitudinal population studies are. If you'd asked me a few years ago, I could have named you the birth cohorts. For lots of studies, data lies on university servers and nobody knows that it's there. Now, if you think of all of this in terms of it's being used, we're using public money for research. You know, that public money could be spent in the health service. So making sure that things aren't lying in what are effectively darkened drawers is a really important reuse and revaluing how that money is spent. And I think the same about the secondary use of healthcare data that Katrina talked a lot about. You know, one of the reasons, so a lot of my work is in routinely collected data, and I like it because I'm particularly focused on underserved groups. And in lots of the studies that we talk about, they're not very represented, but very much, and I can't remember the name of it, the Inukshuk, was that? Inukshuk almost. As well as people with mental health problems, people from underserved groups leave a footprint in all this data and it gives them a voice. So in light of that, we also have 6, and I'm not going to remember them all, we have 6 what we call road builders, where we gave people short, sharp funding to address certain problems. One was NLP that Rob leads. One was discoverable schools. We've done a fair bit of work using education data, and there are many systems around the country. There's Shine in Scotland, Shern in Wales, there's one in Oxford, basically taking questionnaire data to all the children in secondary school in those areas. So there's hundreds of thousands of children, and linking it to their routinely collected data. So the thing about routinely collected data is that it has breadth, but sometimes not as much depth as questionnaire data. So in that road builder, they're sort of creating school dashboards and things. So engaging users, teachers, pupils in the use of that data. During COVID, there was lots of the problems that many of us have in terms of accessing data and pulling data together were overcome in the middle of a pandemic. So there's what's called the longitudinal linkage collaboration that brought lots of cohort studies together with linked data. There's one of those is a road builder, and basically looking at repurposing that. So it was pulled together under what are called COPI agreements that were to deal with the pandemic. And what we've been talking about is, you know, repurposing those things for mental health research. There's one about physical and mental health comorbidity, and we're going to hear that's led by David Osborne, who's going to be speaking tomorrow at the conference. There's one on underserved groups that's led by myself and Dermot O'Reilly from Northern Ireland. Unsurprisingly, we both come from public health backgrounds and we're very focused on those groups. And then last but not least is one on trials. So there's a lot of activity going on in trials in the UK. That's where a lot of the tension for people about working with industry comes into play, you know, which a lot is about trust. And there are 2 things, and this is led by Catherine Abel and Pauline Whelan, and I think you're hearing from Pauline tomorrow as well, which is, one is about ensuring that there's equity. So we know that underserved groups aren't represented in trials. So they've created a tool that really highlights that. And the second thing is there are millions and millions of funded physical health trials run in the UK. And we don't collect consistent mental health data on those participants. And to me, that's just such a waste. You know, so when we're talking about cohorts like Biobank, we're almost creating cohorts in these trials. Two, everyone accepts, you know, when you look at that classic Daly's table from the WHO, and depression is right up there. So we all accept that physical and mental health are intertwined, but we don't do that in a lot of physical health trials, that actually people's mental health diagnoses might have an impact on outcomes. So that's another one. So that's, I think that's sort of DataMind in a nutshell. I mean, it's all over the place. So it really is a network grant. I think it wasn't presented as that, but I really think it works as a network grant and everyone is welcome. This arm, the training capacity development, there's a real it's not a weakness, okay. If you're working with data, there are analytical skills that you need, but if you're working particularly with routinely collected data, there are also domain expertise skills that you need. Now, sometimes that works by working in a certain team, you know, the composition of a team. But I know for the people who've worked on my team that when they start generating that domain expertise themselves, they're working much better in the environment. But there's a capacity issue. We don't have enough mental health data scientists in the UK at all. And then when we train them, sometimes they run off to the private sector, which happened to me last year, and I'm still pained by it. So I guess this is all about creating that community. So we're not just, we're looking for, like, you know, clinicians with interest in data, data scientists with interest in mental health, and finding ways that you can all speak a common language to answer important questions for the people that we're interested in, which I would argue is really the whole population. So I guess we did a survey right at the beginning, didn't we, about the sorts of topics and the sorts of things that would be useful. And that's what we've been trying to deliver in this sort of workshop program. But I don't know if any of you have any other ideas, and we'll bring the mics round.
What about outside of the workshops? Often, like, I work bringing peers together, and just a loose group of people who kind of are familiar with each other, bouncing ideas off each other, is where I think you get the best bang for your buck, because you'll go in with a particular question and you can discuss that. Sometimes like a PPI panel, but with a but instead with your peers, that you can say, look, I've got this idea. It doesn't seem to be working. Kind of, can you help me think about it? So that's not the kind of thing you could do in this workshop, but it might be something that DataMind could facilitate.
So like special interest groups where people could talk and meet.
Yeah, but
I mean, we could, just thinking, I mean, if all that's required of us is to hire a venue, which probably won't be this, but be somewhere cheaper. But, you know, so that people can come together and present to each other on a particular topic. Online better. I mean, it's just online tends to be a bit less interchange. That's the only thing I've tended to find. It's quite difficult that you get a load of big audience, but very few people speak up. That's the only sort of slight problem, but, you know, could be I mean, the dreaded word hybrid, but yeah, I mean, that'd be, I mean, if some people from the group wanted to kind of propose 1 or 2 or 3 or 5 common areas of interest, we could generate a sort of, not quite a seminar series, but a few sort of meeting points.
Sandpits, effectively.
something, a few
Yeah.
kind of presentations to each other, a few people saying, I'd be interested in presenting for 5 minutes on this. You have a few 5-minute presentations to each other and then have a discussion.
And building those networks across each other really is the way forward in your careers. You know, so for me, some of the people that I have had really long-standing work relationships with, I met because of the depression GP validation work years ago. So you know, and then having all those discussions and groups around that sort of work. So it is a really good way to build those relationships across universities.
There's a point I wanted to make about that, actually, just as a not quite sort of take-home message, as it were, is that I don't know, in my research career, things have changed quite a lot in the funding landscape. When I began research, everything you were involved in, unless you were on the sort of trial circuit, was single site sort of studies. You knew your colleagues, you put together a grant bid from your institution. Enormous amounts now of funding calls come out expecting multi-institution bids, and you can't really go for them unless you've got some sense of a network. And if you aren't writing grants, you'll be part of grants sooner or later, and then you'll end up sort of sooner or later having to put them together. And and I think it's probably the way things are going. I think the funders like it. I don't see it sort of changing back to single institutions. And behind all of that is this sort of slightly kind of national sense that governments like to talk about around sort of, the UK being the place for, I mean, in our case, mental health data science. And we can sort of say that because there's not many countries where you could have a meeting like this, where lots of people are coming together in mental health data science. There's not many countries around that have the data resources that we have. When I was growing up, it was all Scandinavia. Scandinavia was the place to be, but the UK is actually quite well ahead of the game, and certainly in our field it is. So I think all of that will come together and mean that these networks are increasingly important, which I kind of like, because I can't stand, institutional rivalries. They're just tedious and distract from everything. And, if you can get things working together, but then the funders sort of want it both ways. They want competition, but they also want collaboration, and somehow you have to negotiate that one. It's not easy, but
all the double speak.
Yeah, exactly. But networks is the solution, because if you end up having to compete for a fund, that's fine. If you're part of a network, you know each other. It's not going to, no one's going to take it badly if you're in one group and someone else is another group. It's okay. So the more you actually do get to know each other and exchange ideas, the better. So,
and I think it's like a bigger version of what Katrina was talking about, of people in a room. I've never failed to not learn, double negative, from networks. You probably have to widen that. That's fine.
Hello, I am from industry, so please don't kill me. But come back to the point around, you said a lot of data scientists start out here and then potentially jump ship to industry. Could it help? Because I know a lot of data scientists, when it comes, or data analysts, when they want to upskill, they want to deliver and learn those things, but they haven't got the opportunities. So could you create maybe projects, as long as the confidentiality was there, could you create projects and opportunities for them to come, deliver what you need, and then almost use their skill sets and then go away again?
So that I think is the ideal model, is that in an ideal world, people will move between being NHS analysts, being in research institutions, and being in industry. But until we get that data sharing bit sorted, people can't do that. And, so we've had through MQ some relationships with industry, but they can't directly touch the data. And we've had agreements that everything will be open source. So I think that time will come, because I think that's the model we need to get to. But I think there's a lot of underlying ethics and ways of practicing that need to be sorted. And I do think what Datamine's doing will go some way towards that. It's finding what we're trying to find in those conversations and the development of guidelines are basically the fences around which you push up against what you can do and can't do.
I think it's also trying to find sort of case studies that work, and that will then sort of inform how we do things. The main problem with going the other way from industry to public is obviously the salary issue, is that you can't move salaries from industry to public sector unless you're happy with it sort of dropping hugely. So there must be some way of people coming in, gaining skills, benefiting both parties, and then probably moving back. I mean, for example, I've supervised a PhD to completion from someone employed as a pharma epidemiologist. She needed a PhD, but it was hard for her because it was the usual thing of, needing to basically be in a full-time job for her employer whilst just negotiating time enough to get a PhD done in amongst it all. But that was one model, which wasn't easy, but it was doable. But there are probably similar things on shorter term that don't involve necessarily a full doctorate, and that could involve some experience where it's nothing to do with the actual employer of the person, and it's just them getting some experience somewhere else.
I was just going to add to that. So I'm a data science coach. Me and my colleague Annie, we basically teach and upskill industry experts to use data science, NLP, time series, all these fancy models. Being passionate about mental health, what can we do right now to use those skill sets, even in a voluntary capacity, to help you guys or the industry, the public sector?
Well, I think start conversations, and we'll keep conversations going. I mean, I think there's ways to make that happen.
And also be part of the industry forum, which is where we're developing lots of this work. And I guess there are ways, we've worked with 2 industry partners really well, but and I guess the second time it was easier because we could develop the collaboration agreements building on past ones. So I think the time is coming. But I think Rob highlighted that the move from public sector and universities to industry, it's very hard to go the other way in terms of life. Are there any other things that people would be keen to see in future workshops?
It doesn't need to be one or the other. It could be a mixture.
I was thinking we could alternate.
Oh, yeah, alternate, or just go according to the votes for whoever's turning up at something. If people vote for it being online, it's online. I think as long as people can commit online to interchange, I think that's the issue. And maybe with a smaller group, that's fine. I think it's my experience of doing online stuff is it's fine for sort of transmitting information and for sort of, pushing projects forward. It can be quite inhibiting for actually sharing ideas where it's a little less focused. But I think it can be, you're right, if everyone's signed up to, I'm not just sitting here as a passive receiver, but these are groups for participation, then I think they can work. And obviously they're much more equitable geographically.
And absolutely hear you about that, because we're based in Swansea, so absolutely hear you about the travel and things. Like in some ways it's there are issues around costs of venues, there are issues around travel connections. Sometimes it is easier to get everyone from around the UK to London because travel networks. So like me going to Manchester is always a plugless, trolleyless trip in the cross-country train. Joyless trip. I love it when I get there. So I guess it's balancing all those things, but I do hear you. Sorry, there were a load of hands up.
Thank you. I was just thinking about what you were talking about, what you guys could do for ECRs, I presume the means of upskilling, giving the data knowledge, also improving networks. And that would be the idea of money for secondments, whether that secondment is in industry or if it's into another team, because I think I'm seeing more small pots of funding, something for someone who's not a fellow, but like coming out of a PhD or a postdoc. Sometimes the problem there is that you can't go do something for 3 months that would get you feasibility data or get you upskilled. It depends on your project whether it allows that. So a secondment would have to have the funding to pay a salary for 3 months and allow you to get those 3 months on the end of your project so you can still meet the deliverables. But that would be a way of like building networks as well. And that's all very dependent on what grants you're funded by and what the money is there. So it was just money is the issue.
Completely. And I guess it's, you know, as we develop and apply for more funding, it's really useful for us to hear what it is that people would want in further development of this arm of DataMind. So, you know, so that idea of funding for small placements. And, you know, network grants often have that sort of funding for ECRs. I know we did in Emerging Minds. I mean, the usefulness of you giving, of like talking about what you want is, even if we can't do it in this iteration of DataMind, we can put forward for the next.
I was just going to say that there are a number of grants now which are just giving money to build networks. So the money, the purpose of the money is for these things to happen. And so there is an argument for us to meet and put together a grant in order to sustain this happening again, because that's a possibility, and that would be a very good reason to meet again, I would say, and think about building a network specifically for early career researchers and data scientists who want to work in mental health, because we don't have it, and that would then possibly sustain us.
I love that idea.
I think we ought to get something going soonish. I mean, probably what is going to be needed is some sort of circular going round, calling for ideas. And if we can pool enough ideas with broad sort of similarities and then sort of put together, I think monthly might be ambitious, you know, maybe every other month or quarterly or something like that. But in between these meetings, at least kind of sort of try and have sort of interim things going where people can join in and get to know each other a bit and exchange. And ideally, you probably want sort of at least sort of 3 or so people saying something at them of pre-prepared material.
Within that, I joined a network. And and it's totally not anything to do with me. They're all midwives. I've joined a midwifery network. I have no medical training. I am not a midwife. I cannot deliver your child. And I joined it anyway. And because they said they were interested in research, and I said, well, I'm a researcher, I'll join it. And I'm interested in maternal research. That's something I'm really interested in. And then I found all of these young midwives who were desperate to do research, but have no way of doing it. And I'm there thinking, but you meet the women I want to do research on. So there's got to be a way of, so I'm now thinking of ways I can involve newly qualified research midwives with research, what's the word I'm looking for? Just really enthusiasm. See if there's a way that there's a study there, something we can do. Anyway, I've joined them. They're happy to have me, and I'm talking to them. But I wonder whether that's how this network could work. There could be people who are clinicians who have research questions, who what they need and what they don't have are data scientists, are the analytical skills. They don't know how to ask the question. They just know it's important. And they could almost come to us and pitch and say, do you know how we could do this? And we can say, yeah, we know how to do this. We could give you the skills. We can work together and make this potentially put in a grant. Do you see what I'm saying?
Absolutely. So we create a network. We have got a network of data mined ECRs in mental health data science. You're all, I'm sure, part of it. So it's saying you're all there, come and ask questions. And it's creating a format that can happen. And then also putting a grant in to fund that.
Just building on that industry, from an industry perspective, we typically do big tech companies will do things called hackathons. So it's a one-day thing, right? This might be what you just said quite nicely. Get everyone in a room together, have the data at hand, even if it's a sample, but by the end of the day, have a tangible output in terms of, oh, we've done the analysis, we've answered this question. Different ways of doing it, but in the process, everyone gets to like upskill and learn the things that they want to learn and kind of collaborate whilst doing that.
So I guess some of the things to look at is, there's the Wellcome Data Prize. There's also, they've got an event going on, I think in June, very much like a hackathon. And I guess one of the things we can mainly do, because I've forgotten to say the important, only thing I was tasked with to say today, our website has launched. Only thing I was meant to say. And it's a really easy URL, so it's datamine.org.uk, and maybe we'll have the capacity through that, because it's got a news section to highlight some of these things that are going on that you can all access. I'm glad that came back to me.
Hi, so I'm going to ask an extremely silly question. It might be that I'm missing the point here, but when you're discussing all these ideas, it also needs, from my understanding, an infrastructure, so an institutional backup. And one of the things that happens with, the midwives you're talking about and many other healthcare professionals is that they may not be linked with the institution. Despite the interest, despite actually maybe even having some skills and now having moved on and been somewhere. So I'm just thinking, how would even in your suggestion, right? The midwives you're working with, and I'm a clinician, I know many of my peers are absolutely not connected with any institution. How to bring those who are interested among that into mental health research.
So I guess there's that idea of having some sort of forum where people bring their questions. I mean, there are grant streams out there like research for patient benefit and stuff, which you need to be working in the NHS or statutory services to lead them. But you always need that partnership with the university, and sometimes it's knowing those people, isn't it? And I guess that's what this sort of the forum that we just talked about would do. And I know that there's at least one grant that I'm involved with that has, the whole concept of it has absolutely came from a clinician noticing something. Any other suggestions now? Otherwise, let us know. We're all around tomorrow.
I think an action point needs to be to circulate to this member or the wider membership the idea of between event meetings, smaller scale, whether they're physical or virtual, can be up to those who want them. And then we can. I'm sure we can find budget for rooms and things like that. If needed.
And whether we can potentially have some sort of format, a bit like a message board on the Datamind, because I do like the idea of people being able to pose questions. I'm not saying we'd answer them, but for people to be able to pick them up. I mean, there's a suicide prevention conference where there was a time when I was on the other side, but now I'm on there, where you have lunch with people. So it's, it's not a formal mentoring program, because that requires funding on both sides. But it's like you get to have a conversation. You know, like say lunch tomorrow, we could organize, we could pair people, couldn't we? I'm not saying tomorrow, but at the next meeting. But that worked really well. I met a couple of people that I ended up collaborating with when I was in ECR. And a few people where I've had lunch with them as a more senior person now, who've then come back to me for references for various things. So, you know, it does work.
At the Ivy then.
Hmm?
At the Ivy.
Oh, yeah, yeah,
You're
yeah.
paying.
To be fair, it was like, you know, a few sandwiches in a corner at the back. Okay, well, are we doing the closing? Or is there someone down to do the closing? I'm very happy to hand the mic over. So thank you all. At the end of the day, it's a really big thing for all of us in terms of developing capacity in this field. And I know, like, for some of the people who've come from more engineering and computer science backgrounds, who've come and worked on my team, that ability to, you know, take those sorts of skills and use it to make a difference in the world is really rewarding. But also for people who are coming from a clinical background to, you know, where you're often responsible for the person in front of you, data gives, you know, it allows you to have an impact at a population level. So I think it works both ways. So we're really, really committed, and I know MQ are completely committed to this sort of training and capacity type work. So I guess part of the onus, it's very easy for us to sit with our really old brains and say, oh, this is what I would have liked, but the world has changed a lot. So you know, let us know. It has to come from you, what's useful. Like, we were quite surprised at the outcome of the workshop results. They weren't what we were expecting, were they? With programming and stuff. So thank you all. I hope lots of you are coming tomorrow. There are loads of really good speakers. And we'll all be around tomorrow. So thank you. And thank you to Parissa and Hala and Marcos for organising these workshops.